It's my pleasure to be here in this big conference and congress regarding global healthcare and biomedicine in order to present my team's current research to you sophisticated audience. Actually, my team's current research is regarding hepatocellular carcinoma and so-called HCC, which has been converted to one of important anomalies these days. You know that one of the most important way in order to control such abnormalities such as the hepatocellular carcinoma is nothing but using some special medications in the name of immune checkpoint inhibitors. But there are two important factors for such medications. The first one is their cost, and the second one is nothing but their efficacy. That's why the patients who are suffering from the hepatocellular carcinoma have a lot of stress when they want to choose these drugs as a treatment. They have to pay for these drugs periodically, and at the same time they aren't sure about the efficacy of such medications. So my team has been decided in order to initiate a type of retrospective and prospective research regarding this matter in order to make a bridge between the efficacy of immune checkpoint inhibitors on treatment of the hepatocellular carcinoma with human genome. Let's focus on the PPT in order to have a brief discussion regarding our project.
Immune checkpoint inhibitors and so-called ICIs have transformed the therapeutic landscape of hepatocellular carcinoma. But treatment responses remain highly heterogeneous, and currently available biomarkers such as PD-L1 expression provide limited predictive value. Emerging evidence underscores the pivotal role of immunometabolism, including T-cell exhaustion, metabolic reprogramming, and cytokine signaling in shaping ICI efficacy within the tumor microenvironment. A multidimensional approach that integrates immune and metabolic parameters holds promise for enhancing predictive precision. To address this need, the present study aims to develop and validate a predictive model for ICI response in hepatocellular carcinoma by combining retrospective clinical and immunometabolic parameters with prospective profiling of immunometabolism-related gene expression. In order to achieve this aim, a hybrid retrospective prospective study design was implemented. In the retrospective arm, including 60 patients, clinical variables such as TNM staging, HBV status, and BMI were evaluated alongside immune markers such as PD-L1 and CD8 expression assessed by immunohistochemistry, and cytokines such as interferon gamma and interleukin-6 measured by ELISA. Metabolic indicators, including lactate dehydrogenase, glucose, and triglycerides, were also analyzed using archived patient records and serum samples obtained at our hospital. In the prospective arm, including 15 patients, fresh or frozen tumor biopsies from patients treated with immune checkpoint inhibitors were processed for RNA extraction, followed by cDNA synthesis and SIB green-based quantitative PCR to assess expression of key immunometabolic genes, including PD-L1, GLUT1, IDO1, CPT1A, TIGIT, and interferon gamma. Data integration and analysis involved the application of multivariate logistic regression, principal component analysis, and machine learning models to construct a predictive tool with model robustness and accuracy assessed using receiver operating characteristic, curve analysis, and k-fold cross validation. Our purpose is to establish a clinically deployable biomarker panel with greater than 85% sensitivity and specificity for stratifying immune checkpoint inhibitor responders. In addition, it's expected to generate molecular signatures that link gene expression profiles with treatment outcomes, thereby providing deeper insights into therapeutic response. Building on these findings, a decision support tool in the form of a stratified immunotherapy guidance flowchart will be developed to facilitate personalized treatment selection for hepatocellular carcinoma. Finally, the project is designed to provide foundation data that can support the extension of immunometabolic predictive strategies to other solid tumors. If the project goes successful, we're going to bring a novel integrative immunometabolic model for predicting immune checkpoint inhibitor response in hepatocellular carcinoma with a strong translational potential in precision oncology. The dual-arm design and multi-omics integration not only enhance predictive accuracy, but also bridge clinical and molecular domains, offering a data-driven approach to personalized immunotherapy decisions. Thank you very much for your listening and patience. I hope everyone good luck.
India. My study was a comparison of the two administration modalities of subcutaneous enoxaparin injection on formation of ecchymosis. Wellness encompasses a healthy body, a sound mind, and a tranquil spirit. Enjoy the journey as you strive for wellness. I encode Laurette Gangan Bellew. Low molecular weight heparin is a new class of anticoagulants derived from unfractioned heparin, UFH. Enoxaparin, a low molecular weight heparin, is commonly used in all our critical care areas to prevent thromboembolic disorders such as pulmonary thromboembolism, acute coronary conditions. However, this drug has certain side effects such as subcutaneous bruising, which is also known to be the most common adverse effect of this drug. Nurses play a unique role in the administration of drugs for treatment, prevention, and diagnosis of diseases. Subcutaneous heparin administration is routinely used for many patients in our critical care areas. So, our nurses most frequently encounter ecchymosis formation with heparin administration. The factors of local bruising to subcutaneous enoxaparin injection include the injection site, the administration modality, injection time, and the rubbing time after injection. Therefore, nurses should know the factors associated with the occurrence and intensity of the above-mentioned complication. So the need for my study was a safe injection should not harm the recipient. It should enhance the effectiveness of medicine and protects the rights of the patient. Out of various subcutaneous injections, enoxaparin sodium mostly causes local reactions. And on the other hand, one of the important role of our nurses is to practice safe injection techniques. There's a reported incidence of 20.6% to 88.9% of ecchymosis following subcutaneous injection of this drug. So it is a very clear indication of such a complication. The most importance of administering injection LMWH in reducing the incidence of ecchymosis is crucial, and applying the same in clinical practice will reduce the patient's discomfort, tension, and worry, as well as their distress towards nurses. So the problem statement of my study was a study to compare the two administration modalities of subcutaneous enoxaparin injection on formation of ecchymosis among the patients admitted to the critical care unit of a tertiary care hospital in Western Maharashtra, India. Aim of my study is to compare the administration modalities of subcutaneous enoxaparin injection on formation of ecchymosis. The main objectives of my study was, I have kept two objectives for my study. One was to assess the effect of administering modalities of subcutaneous enoxaparin on formation of ecchymosis, and second, to find the association of ecchymosis size in administration modalities of subcutaneous enoxaparin injection with the socio-demographic characteristics and clinical factors of study participants. So my operational definition, administration modality, I mean administering subcutaneous enoxaparin injection over 10 seconds duration at one side of abdomen, and second, administering subcutaneous enoxaparin injection over 30 seconds and waiting for an additional 10 seconds before withdrawing the needle at other side of abdomen. Both A and B in the same patient was conducted at an interval of 12 hours apart. Enoxaparin means pre-filled syringe of enoxaparin injection, that is low molecular weight heparin, kept at room temperature. 3. Ecchymosis means a flat blue or purple patch measuring more than 1 centimeter in size. My assumption for my study was administering enoxaparin in 10 seconds may cause more of ecchymosis, and administering enoxaparin in 30 seconds and waiting for an additional 10 seconds before withdrawing the needle will help in reducing the size of ecchymosis. The delimitation of my study was, the study was actually limited to the patients receiving enoxaparin as a part of their treatment protocol. Consumption framework, I have used Donabedian's conceptual framework of structure, process, and outcomes. My structure was a critical care unit with a patient of 100. Nurses were included. Enoxaparin injection and injection equipment was pre-filled syringes. Process was 10-second injection, 30-second injection, and measuring injection duration with a proper skin marking and needle removal and insertion. My outcomes were, I have measured the outcomes in ecchymosis size, that is in centimeters, frequency of ecchymosis, and patient satisfaction. The ethical clearance was obtained from the ethical committee of the institution. Consent from samples were taken at the time of data collection. Review of literature, I have mainly cut short the review of literature into 3 important ROL which I have selected. One was regarding the use of enoxaparin by Michaela M. Buckley and Eugene M. Sorkin in 2012. They have showed the importance of enoxaparin and its uses in preventing the disease conditions. Second, Zinab et al. In 2019 conducted a study on the incidence and extent of bruising after subcutaneous enoxaparin injection. So he has also done the study and chi-squared the test, and then the bruising was less according to his control study. Third was R. Gennaro Collado in 2017. He has conducted a study on ecchymosis and hematoma formation after prophylactic administration of subcutaneous enoxaparin. In the study, he has compared the arm and abdomen as the site for more of ecchymosis or not. So considering these 3 ROL as the main part of my study, I've gone with the study. Methodology, I have done a quantitative research approach. Crossover study design was conducted. My sampling technique was convenient sampling technique with a sample size of 100, patients aged 35 to 75 and receiving 40 to 60 mg injection enoxaparin every 12th hourly. Study selection of study sample. My target population was critical care patients receiving enoxaparin injection as a part of their treatment protocol. My accessible populations was patient aged 35 to 75 years of age. Sampling technique was convenient sampling, and sample size was 100 patients receiving injection enoxaparin as a part of their treatment protocol. Tool preparation, my tool had 2 sections, that is section A, demographic data, and section B, observation checklist for administration modalities. Data collection procedure. This was the important part of my study because I have selected an appropriate site for injection was selected in the lateral part of the abdominal area, which is about 5 centimeter around the navel. Alcohol was sprayed and injection site was disinfected. After removing the needle cap, the Pre-filled syringes are kept at a room temperature. The needle was inserted at an angle of 90 degrees after pinching up the skin on injection site. Then the injection duration was calculated using a wristwatch. After injection, the needle was smoothly removed and the site was pressed by cotton wool. Next, the injection site was marked with waterproof marker in a circle with radius of 2.5 centimeter in order to prevent further injections on that site and to be able to evaluate the bruise size. Blue and red markers were used to mark the 30 and 10-second injection site respectively. 30 seconds injection and 10-second delayed withdrawal was marked with blue on the one side of the abdomen, and the other side of abdomen was marked with red marker for 10-second injection. Then the subject, my participants were educated to prevent rubbing, touching and pressing of the injection site. Next, injection was administered after 12 hours on the other side of the abdomen in such a way that the patient for whom the first injection was given for a 10-second duration, the next was given after 12 seconds. That was administered for 30 seconds and then vice versa. Finally, after 48 hours of the injection, the size of the bruising was marked on a transparent paper and measured by graph paper, that is centimeters. All injections, measurements, bruise size calculation were conducted by the principal researcher. Data analysis, I've used descriptive as well as inferential statistics. And coming to my analysis and interpretation. I have kept two groups, that is control group as well as study group, and I've classified on the basis of intervention, time period, withdrawal time, and observation of ecchymosis. For the control study and the study group, the intervention was same, that was subcutaneous injection enoxaparin, pre-filled syringes kept at room temperature. Time period for my control group was within 10 seconds and study group was for 30 seconds. Withdrawal time, immediate withdrawal of the needle, 10-second delayed withdrawal of needle for the study group. Observation of ecchymosis, 48 hours post-injection, and the other was also observed 48 hours post-injection. So this multiple bar chart depicting the percentage distribution of study participants. This shows that after immediate withdrawal, there was 12% formation of ecchymosis, then 35% and 53. So with the 10-second immediate withdrawal, 53% of my patients have developed large ecchymosis, whereas 30-second with 10-second delay withdrawal has shown a sudden graph down, that is only 17% has developed a large ecchymosis, whereas small ecchymosis was developed by 61%. Then this is a pie chart showing the percentage distribution of sample by dosage of injection enoxaparin. 40% received 44% received 40 mg injection and 56% received 60 mg injection enoxaparin. Comparison of mean between ecchymosis size by injection techniques. So this has shown that with a p-value of less than 0.01, 10-second with immediate withdrawal, the mean and standard deviation was 2.44 plus or minus 1.22. And with 30-second with 10-second delayed withdrawal, keeping the n as 100, mean standard deviation was 1.17 plus or minus 0.82, and the p-value was less than 0.01. So the result of my study was the comparison of ecchymosis size after 48 hours between subcutaneous injection enoxaparin administration modality revealed that 10-second immediate withdrawal protocol resulted in significantly larger ecchymosis size compared to that 30-second with 10-second delay withdrawal protocol. Implications. The findings of the study have important implication for nursing practice, nursing education, and nursing administration and nursing research. For nursing practice, the nurse can practice that with applying the injection for 30 seconds and delayed withdrawal of 10 seconds can decrease the ecchymosis to a large extent. Nursing educators should educate the upcoming nurses to practice the following, and nursing administration can include these study as for their upcoming syllabuses. And for nursing research, more of nursing research can be conducted using larger sample size. Limitations: limited sample size. My sample size was 100, so a more extensive study can be done with a much larger sample. And variability of injection: I have just selected the abdomen as an injection site. We can further do researches using the thighs and the arms as sample as injection sites. Recommendations: adoption of optimal injection techniques can decrease the ecchymosis sizes, as well as the trust towards the nurses, and the patient's discomfort will be reduced. Standardized protocols regarding injection LMWH can be used all over the world so that we can decrease the patient discomfort to a larger extent. Training and education of healthcare providers, timely checking of the techniques and educating our clinicians will be a great use for this. Conclusion: the study contributes valuable insights in the role of injection technique, dose of heparin, and patient history in the formation of ecchymosis following subcutaneous enoxaparin administration. The findings suggest that modifying the administration modality to a 30-second injection with a 10-second delay can effectively reduce the size of ecchymosis, particularly in patients receiving higher doses of the drug. So these results underscore the importance of individualized patient care and the careful consideration of clinical and procedural factors to minimize adverse outcomes in patients undergoing anticoagulant administration. Adopting this technique in critical care units may help in improving patient comfort and minimize the injection site ecchymosis. Thank you, and I'm deeply grateful for the opportunity to share my study with all. Thank you.
Thank you, Rocky, for your excellent presentation.
Today, my presentation is based on a case presentation. My topic is AL amyloidosis in a middle-aged lady, confronting the challenge of a rare diagnosis in a developing country. Our patient is 37 years old, mother of 3 children and housewife, who presented with loss of appetite and loss of weight for 3 months duration. And also she noticed frothy urine with low abdominal pain and significant altered bowel habits with constipation. She doesn't have any chronic cough, alopecia, skin rashes, joint pain, fever, hematuria, or generalized edema. And her past medical history and past surgical history with allergic history is uneventful. On examination, the patient was not pale and is not icteric, and there were no facial puffiness, ankle edema, but she had cervical lymphadenopathy with hepatomegaly of 10 cm below the right costal margin. Her cardiovascular, respiratory, nervous, and locomotor systems were within normal limits. Moving on to the investigations, her hemoglobin was 10.5, indicating moderate anemia with normal WBC and platelet. Her serum albumin was 39, that is normal range, but the total protein was within the upper limit of normal. And her bilirubin, AST/ALT was normal, but the alkaline phosphatase was high. Sodium and potassium was normal. Moving on to the renal functions, her serum creatinine was normal, but the urine for albumin was positive, with UPCR was higher than the normal range, and the 24-hour urine protein excretion was 1,555 mg, indicating subnephrotic proteinuria. So the blood picture, there were mild normochromic normocytic anemia with moderate Rule formation with mild lymphocyte predominance. In the coagulation profile, even though she denies any bleeding manifestations, her APTT was prolonged, but the mixing studies were corrected with inhibitor testing was negative. So ESR was high persistently, but her serum calcium, LDH, TSH, and PPBS was normal range. Her ultrasound scan abdomen showed hepatomegaly with no paraortic lymphadenopathy, and the ultrasound scan neck showed few prominent lymph nodes with preserved fatty hilum in both sides of the neck. Her ANA was negative. So this is a 37-year-old lady who presented with constitutional symptoms, altered bowel habits, cervical lymphadenopathy, hepatomegaly, subnephrotic range proteinuria with high ESR and high alkaline phosphatase. So we did the serum protein electrophoresis, which we identified prominent monoclonal band in the gamma region with estimated paraprotein level of 17.7 gram per liter. The serum protein immunofixation identified this paraprotein as IgG lambda, and the serum free light chain assay, there were increased lambda light chains of 126.21 milligram per liter with involved lambda to kappa light chain ratio was 8.97. So the urine protein immunofixation, there were monoclonal excretion of heavy chain and lambda light chain fragments. So we did the bone marrow examination where we identified 20% are pleomorphic plasma cells, including binucleated and trinucleated forms, and there were occasional plasmablasts also. So with this subnephrotic range proteinuria, hepatomegaly, and paraproteinemia, bone marrow findings were keeping with the diagnosis of plasma cell dyscrasia. So the possibilities were whether this is amyloidosis or a lymphoplasmacytic lymphoma or multiple myeloma. So we did the trifine biopsy, where the trifine biopsy identified interstitial deposition of amorphous waxy-looking eosinophilic material, and these deposits are occasionally seen in the thickened blood vessels. We identified there are prominent plasma cells as well. We did the CD138 immunohistochemistry, where we identified positivity in the plasma cells, but we couldn't elicit apple green birefringence on the congruent stain in special stain with congruent. But we did the renal biopsy as there is renal involvement, where we identified glomeruli show mesangial matrix expansion by eosinophilic pale material, and the congruent stain showed apple green birefringence, where the features are keeping with the diagnosis of amyloidosis. So we did the abdominal fat pad aspirate. There were no evidence of amyloidosis, but the lymph node biopsy showed amyloid deposits, as you can see in the picture. In the CCT neck to pelvis, there were hepatomegaly and cervical lymphadenopathy, but no other abnormality. There were no lytic lesions on bones skeletal survey. And the lower GI endoscopy, there were no bowel pathology and no amyloid deposits identified. So the patient was diagnosed to have systemic AL amyloidosis. What is amyloidosis? It is a disorder of protein folding in which normally soluble proteins are deposited in the extracellular space as insoluble fibrils that progressively disrupt tissue structure and function. Clinical amyloidosis syndromes are classified according to the fibril protein. These are the different types of proteins that can have different types of amyloid. So the serum amyloid A component is due to the due to the chronic inflammatory conditions, while the transthyretin level can be seen in the hereditary forms and mainly with the cardiac involvement. AL amyloidosis is a monoclonal immunoglobulin light chain fragments are accumulated as beta-pleated sheets and ultimately leads to organ failure. So the most commonly affected organs are the kidney, heart, liver, and peripheral nervous system. But according to the global epidemiological data, the majority of AL amyloidosis patients are over 65 years old. Even though most of the patients presented in their 7th decade, the progression would have happened for several years of its onset. So in our patient, presentation at 37 years old is very rare. So AL amyloidosis could be associated with myeloma or other B-cell malignancies such as Waldenström macroglobulinemia or marginal zone lymphoma. So when there is an underlying plasma cell clone, there is excess production of unstable free light chain. So the misfolding light chains allow exposure of hidden epitopes which allow aggregation. There will be prefibrillar aggregates and will cause direct tissue toxicity. And these fibrils form beta-pleated structures which give rise to different clinical manifestations in different organs. So when investigating for amyloidosis, first you have to confirm the amyloid and then need to determine the amyloid type and then the organ involvement and underlying plasma cell dyscrasia to be identified. To confirm the diagnosis of amyloid, the histological diagnosis is needed as we did in our patient with renal biopsy, bone marrow biopsy, and for the abdominal fat pad biopsy. So the subscintigraphy, which is not available in our country, is used to demonstrate the amyloid deposits in a quantitative manner. To establish the fibrillar type, the presence of a paraprotein does not per se confirm the diagnosis of AL amyloidosis, which needs the exclusion of serum amyloid A component and the transthyretin forms. So it needs immunohistochemical staining for the fibrillar protein or the proteomic analysis or the gene associated with hereditary amyloidosis. But in our country, those investigations are not available. So we have excluded the chronic inflammatory condition in our patient, and also we identified this plasma cell clone and the paraprotein level. So with that, we came to a conclusion that the probable diagnosis would be AL amyloidosis. So we have done the underlying plasma cell dyscrasia as I mentioned previously. So to assess the organ involvement, it has to be done with the renal function, liver function, and cardiac function, especially with the nervous system. For staging, cardiac markers play a critical role. According to the revised Mayo Clinic, NT-proBNP, cardiac troponin, and difference in pre-light chain are used. So in our patient, she was in stage 1 disease as the cardiac involvement was not there. So the principles of treatment include the chemotherapy aiming to suppress the plasma cell dyscrasia. So mainly the chemotherapy regimes are based on multiple myeloma, and supportive therapy is an important factor. Treatment can be very challenging because the benefit typically does not occur for many months, and the treatment has to be individualized. And often there's an asynchrony between hematological and organ response, and there can be treatment-related toxicity, and the unavailability or unaffordability of ideal treatment with poor resource constraint in developing countries is also there. So the goal is to rapid and deep hematological response. Organ response can sometimes be delayed. So according to the American Journal of Hematology, the new guidelines says that if the patient is transplant eligible, the patient should be started on daratumumab with cyclophosphamide bortezomib dexamethasone, and then achieve for the partial response or hematological response, and depending on the response, go ahead with the autologous stem cell transplant. For the transplant ineligible patient, first-line treatment, again, the daratumumab with cyclophosphamide dexamethasone, then achieving the response, and then go ahead with the maintenance with daratumumab. There are some prospective studies where upfront bortezomib results in deep and durable hematological response. The bortezomib, the drug that we used in our patient. Daratumumab is a human monoclonal antibody against CD38 antigen, and it is highly effective anti-plasma therapy producing deep response. But we couldn't use it in our patient. So this study design Andromeda, which give the results of higher rates of responses observed with Dara-Cybodex when compared to the Cybodex alone. Autologous stem cell transplant has a renal and cardiac organ response, and high complete hematological response rates has been reported after the stem cell transplant, and their 10-year survival is about 25%. Venetoclax can be used in translocation 11-14. And this anti-amyloid antibodies, bertamimab, is the only investigational therapeutic drug which showed antibodies designed to bind to epitopes on the fibril in managing the amyloidosis. For the relapse refractory setting, daratumumab has again the role, and the other drugs are the pomalidomide dexamethasone, lenalidomide dexamethasone, carfilzomib, venetoclax, and bendamustine. So the general supportive care is very important as MDT approach with managing the renal involvement, congestive cardiac failure, bleeding and thrombotic prevention, nutritional and psychological support. So moving back to our patient, we did the pre-treatment evaluation with viral screening, echo, and the other investigation. To assess the amyloid-related complications, we did the echo, nerve conduction studies, which were normal. Her echo performance score was 0. We have taken the consent, and we have given the chemotherapy cycles of cyclophosphamide, bortezomib, dexamethasone. So the concurrent medications continued: allopurinol, acyclovir, proton pump inhibitors, fluconazole. So according to the guidelines, the hematological response, the complete hematological response is serum, negative serum and urine immunofixation with normal free light chain. VGPR, very good partial response, is difference in free light chain below less 40. And the organ response also categorized with different criteria with kidney, heart. So in our patient, after 3 cycles of cyclophosphamide, Cybodex, bortezomib, dexamethasone, as paraprotein level came down to 9.1 from 17.7, and the serum free light chain, the difference was reduced from 111 to 16, which showed a very good partial response. But in organ response-wise, her 24-hour urine protein excretion after 3 cycles, which was 1,555 milligram, were increased to 3,537. So we saw a disease progression after 3 cycles. Cardiac and the liver status were same, but so we referred the patient to the autologous stem cell transplantation. So we identified that progressive organ disease despite very good partial response in hematological response. So we started on irbesartan for the proteinuria and endocrine referral for blood sugar control. So we completed total 9 cycles because we want to reach until the transplant is available. So after 9 cycles of Cybodex, then 17.7 came to 2.2 with the difference in free light chain was marked reduction from 112 to 3.81. Urine 24-hour urine protein also came down. So the patient has undergone autologous bone marrow transplant under melphalan conditioning. Post-transplant, she recovered following neutropenic sepsis. So the serum protein electrophoresis after this 6 months after the transplant. Before the transplant, it was 2.2, but gradually we identified 6 months after the transplant, the paraprotein level came to 3.8, and the difference in free light chain, which was 3.81 to 34.3, gradually increased. 24-hour urine protein also gradually increased from 691 to 1,200. So there is a gradual increase in difference in free light chain levels and increase in 24-hour urinary protein excretion. So she is currently on follow-up with the plan of restarting chemotherapy cycles with bortezomib, lenalidomide, dexamethasone, as daratumumab is not affordable in our setup. So in conclusion, amyloidosis is a rare disease that can be complicated due to a long delay in diagnosis, causing major organ impairment. Morbidity and mortality can sometimes be limited if diagnosed earlier. Despite the low incidence of AL amyloidosis before the age of 40, monoclonal gammopathy workup is an important aspect in patients with compatible clinical picture regardless of age. Targeted biopsies should be performed to confirm the diagnosis and start the treatment early to prevent organ failure. Despite the early diagnosis and treatment of AL amyloidosis, limited accessibility to optimum treatment options like daratumumab in disease progression is a major drawback in managing patients in developing countries. So these are my references from American Journal of Hematology, British Journal of Hematology, and the Blood Journal. And these are my supervisors, Dr. Yenifa Samaravira, Dr. Nishada Ranasinghe, the consultant hematologist in Colombo South Teaching Hospital, and the Dr. Mujahid, the consultant physician from in our hospital. And there are no conflict of interest with others. And this is my team in Colombo South Teaching Hospital. And these are some beautiful pictures from our country, our beautiful country, Sri Lanka. Thank you for giving me this opportunity to share my experience with our patient. Thank you.
In postpartum rapid cardiopulmonary deterioration and the congenital pneumonia in the neonate, like how the factors, how it impacted maternal health and also the neonatal health. If anyone do have question, even in between of the presentation, you can just come up in between and let me know. So let me initially give you an overview of what happened to the mother initially. The mother was a 31-year-old gravid to para-1 with 36 weeks gestational age with obesity and hypothyroidism has presented to the outpatient department with a complaint of subjective fever, dyspnea, and also cough. On examination, her vitals were relatively within normal limits, with CRP was mildly elevated, showing 7. The normal range is less than 5, and a 2D echo revealing grade 1 diastolic dysfunction, which is generally overlooked in obstetrics because of the physiology of the pregnancy. And eventually, because of the persistent fetal tachycardia and maternal increase in subjective dyspnea, the combined obstetric and the pediatric team, along with an input from a general physician, was taken to deliver the baby. So the delivery was by cesarean section and it was uneventful. And later, on the first post-operative day, the mother started to have increased dyspnea and orthopnea with again relatively stable vitals, but the chest X-ray showed bilateral pleuroeffusion and consolidation in the lower lobes. So we began the initial support of oxygen along with the therapeutic antibiotics, like covering the atypical microorganisms too, and along with the antiviral, suspecting it to be a pneumonia, like oseltamivir. She showed initial improvement, but on the post-operative day 2, her saturation got worsened, which initially on the post-operative day 1, her saturation was relatively stable. On post-operative day 2, her saturation was around 86 to 88%, and we did a CT scan of the chest, which showed bilateral consolidations at the lower lobes and also in the right middle lobe segment. And her CRP was elevated to 69, and her 2D echo revealed grade 2 diastolic dysfunction, which is showing that both her cardiac and also her respiratory functions were declining. And eventually, the treatment was continued. We reduced her IV fluids and also increased the oxygen support and also early mobilization chest physiotherapy, all of which helped her to resolve. And she showed improvement from the post-operative day 4. And she was in the hospital till post-operative day 8, which showed progressive improvement, and later we discharged. So the final diagnosis of the mother was community-acquired pneumonia with subtle grade 2 mild diastolic dysfunction. So coming in here, what are the factors that had accelerated this maternal deterioration? That is what I want to highlight about. She's a 31-year-old female, but she's obese. Her pre-pregnancy BMI was around 37, which according to the WHO classification comes under grade 2 obesity. And around when she presented to the OPD at 36 weeks, her BMI was around 41. And she's also short-statured, which is around 4 feet 7 inches, which is around 140 centimeters. All of these factors are additive and showing that her pulmonary reserve was relatively low compared to the normal population. And also the perioperative factors like anesthesia and also shallow breathing because of the incisional pain and the limited mobility in the initial part after the surgery, and also these IV fluids, all of them together cause pulmonary congestion because all of these factors might lead to reduced clearance of the lung fluids, and so paving the way for bacteria to grow. And later on, along with this, the postpartum dynamics, that is, initially it was the placenta that was maintaining the low vascular systemic vascular circuit, but the abrupt removal of the placenta post-cesarean section causes an increase to the systemic vascular resistance. And also the involution of the uterus causes an autotransfusion of the uterine blood into the heart, increasing the preload. So a combination of increasing the preload and afterload might have increased the cardiac strain, leading to worsening of her diastolic dysfunction to grade 2. And eventually her inflammatory response, like when CRP was monitored, preoperatively it was 7, on the post-operative day 1, it was around 63, on post-operative day 2, it was 69, and that was the peak on the post-operative day 2. So these are the pictorial presentation of the graphs of the CRP trend and the WBC trend. showing increase on the post-operative day 2 to the max. I'm sorry, this is if it's not clearly visible regarding the WBC trend, showing that these two were predominantly increased on post-operative day 2. So what insights can we get from this case? Like how can we prevent this in the future? So the first thing that we avoided in our case was we did not do imaging antepartum because there is always a fear that of the fear of radiation, it might impact the neonate or the fetus. So the imaging was avoided. The chest X-ray was avoided in the antepartum stage, and low dose of chest X-ray would not be harmful, as the evidence supports to go for chest X-ray if there is anything suspicious. So early imaging might have prevented this diagnostic delay. Considering the post-operative day 2 to be the worst for a patient, and looking back to the evidence and the literature reviews, most of the morbidity and mortality for the postpartum woman was seen on the post-operative day 2, indicating that this is where the worst things happen, because this is where the physiological shifts happen for the pregnancy. And so the close monitoring was required during this period. And it is also important that individualized IV fluid should be given based on patient to patient rather than just being vague and generalized protocols for every postoperative woman. So early mobilization would have been helpful to prevent the accumulation of the fluids in the lung, and early chest physiotherapy would have been helpful. And there should be a standardized protocols like early escalation triggers when the respiratory rate is rising and saturation is dropping below 94, and monitoring of the CRP when required. The preventive learnings here were our patient did have a prior history of preeclampsia in the previous pregnancy, but there were no such complaints in the current pregnancy. She was normotensive all throughout the pregnancy, and there were no signs of organ dysfunction. But the evidence does suggest that a history of preeclampsia, even though it's once in a lifetime, does have persistent endothelial dysfunction going on in the body, which can be attributed to the mild amount of diastolic dysfunction to this patient, because the inflammation the preeclampsia contributes to the body is a continuous process, where the evidence shows that women with a history of preeclampsia do have cardiovascular events more compared to the women without any history of preeclampsia in their lifetime. The mechanism that can be contributing to this is a persistent endothelium dysfunction and heightened sensitivity of angiotensin 2 and also endothelium receptors dysregulation. These are some of the factors that we should all keep in mind, that a history of preeclampsia in a woman cannot be neglected. And also, weight optimization is definitely an important factor that we should consider pre-conception, and also a targeted gestational weight gain for each individual woman, as obesity increases overall obstetric risk, not only for gestational diabetes mellitus or preeclampsia or intrauterine growth restriction, but also there is some kind of limited understanding how actually maternal obesity influences the postpartum period, so requiring a more research to be done on this aspect. And the subtle risk that a patient had was obesity, short stature, and also both of these led to the reduced pulmonary function, reduced pulmonary reserve, and also there was a mild lower respiratory tract infection initially, and the postpartum shifts, and all of these were, the subtle risk, but together they were cumulative, like highlighting that how tiny factors should be considered while dealing with the postpartum women. And also right now with the AI coming up, it might not be clinically feasible to take every little thing into consideration, but using AI, we can just gather up all the scattered subtle points, and together we can stratify the patients into low risk, moderate risk, and high risk, and thereafter tailor the treatment appropriately to each patient. So coming to the neonate, the mother had delivered female with 36 weeks gestational age with 2.5 kg weight, and with Apgar showing 7 and 9 at 1 and 5 minutes respectively. Initially, the baby was fine with stable vitals with stable preductal and postductal saturations too. But within 15 minutes of birth, the baby started worsening. There was increase in respiratory rate, which was about 80, and tachycardia, which was approximating to 200s, and saturation was dropping down despite starting on the basic low flow oxygen cannula for the nasal cannula for the baby. The saturation was around 82 to 86. Sometimes it was even dropping to 78. And the random blood sugar levels after the delivery showed 33, indicating that there was something that is going on in the baby rather than just transitional. And the baby eventually started developing grunting, nasal flaring, and retractions, which were both subcostal and intercostal. So as the respiratory support of baby increased, we increased to NIPPV, positive pressure ventilation, and began the antibiotics early with a view that mother already had the infection, so the infection might have already been established in the baby. That is why the baby respiratory support have been increasing on and off rather than just being transient tachypnea of the newborn. The chest X-ray of the baby showed bilateral infiltrates, which even supports our diagnosis of congenital pneumonia. Because for the TTNB, I mean transient tachypnea of the newborn, the chest X-ray or the imaging generally shows hyperinflated and the fluids in the fissure, which was not the case in our neonate. And antibiotics were immediately began to the neonate with broad spectrum according to the NICE guidelines. The NICE guideline says that if there is an established maternal infection before the delivery, along with hypoglycemia, hypoxia, tachypnea, and tachycardia in the newborn, treated as an early onset sepsis. So we began to treat the neonate as the early onset sepsis and initiated the treatment for the appropriate antibiotics with the amikacin and piperacillin tazobactam. And the baby began to show the improvement in the next few days. The clinical insights that we can get from this neonatal case is like the early distress along with tachypnea, tachycardia, retractions, which can be seen as a part of TT, transient tachypnea of the newborn too, but the hypoglycemia and early deterioration despite escalating the oxygen support showed that it is not just something transitional after the cesarean section, but rather something pathological going on with the baby. So according to the EOS, we should always remember that these protocols, we should start antibiotics irrespective of waiting for the cultures. Whereas in our case, the cultures, both for the maternal and also for the neonate, were negative. Even the placental culture showed no growth. So it's suggesting that we should not just depend upon the cultures and waiting to start for the antibiotics. Rather, it's just an important, crucial time for us to just begin the antibiotics empirically based on the appropriate standardized protocols. And whenever the preventive learnings from this neonate is whenever there is an established maternal infection or fever, or at least a suspicion of infection, classify the newborn as a high risk because there is definitely a higher chances of transplacental transmission of infection. And also ensure a proper communication between the teams from the obstetric and also the neonatal team handover. And consider the neonate as a high risk and deal accordingly, assessing whatever the high risk, how to exclude it. And to summarize, recognizing all these issues early and intervening promptly was the important thing that prevented worsening in both the maternal and the neonatal case. Yes, obviously, whenever there is a maternal infection or there is a suspicion, it is always better to be prepared regarding the neonate to deal with the worst. And it is important to concentrate how these subtle risk factors which were generally overlooked when combined could cause a cumulative risk. And these are the risks that deteriorated the mother in our case. So definitely every risk should be considered important. And as we have seen, the first 24 to 48 hours postpartum is the worst scenario for the mother, and that should be monitored clinically as it can make the biggest difference. And thank you. If you have any questions, I'm open to them all.
Thank you, Doctor, for your wonderful presentation.
Post-cholecystectomy incisional hernia with gastric outlet obstruction. So the summary of my case is this is a very rare case of 50-year-old woman with 2 years of recurrent vomiting and epigastric swelling after an open cholecystectomy. Initially, a CECT suggested pyloric thickening and raised suspicion of malignancy, while endoscopy failed due to distorted anatomy. A repeat CECT scan eventually revealed a large supraumbilical incisional hernia containing the greater curvature of pyloric antrum of the stomach, causing gastric outlet obstruction. Upon surgical exploration, the findings were confirmed, adhesiolysis was done, the stomach was reduced, and the defect was repaired with onlay mesh. The patient recovered well without any recurrence. This case highlights the importance of high suspicion, proper imaging, and timely surgery in diagnosis rare gastric herniation through an incisional hernia causing gastric outlet obstruction. So, what is an incisional hernia? Incisional hernia, it's a ventral hernia occurring at a previous surgical incision. It commonly contains great omentum or a small bowel, but the gastric involvement in such cases is extremely rare. The importance of this case is the gastric outlet obstruction due to incisional hernia is very uncommon. It is easily misdiagnosed because the symptoms resemble peptic ulcer or any other malignancy. Only a few reported cases have been come to the point. Okay, the risk factors include the old age, obesity, diabetes, and smoking. Previous abdominal surgeries, multiple pregnancies, and surgical site infection may lead to gastric outlet obstruction. So the patient, 50-year-old female, she presented with the chief complaint of intermittent nausea and vomiting. She had postprandial discomfort and epigastric swelling which increased with sitting, coughing while relieved with lying down. She had a history of hypertension, thyroidectomy, open cholecystectomy 2 years earlier, and a 2 year of intermittent vomiting and epigastric swelling. Initially, she had an ultrasound which had 37 millimeter defect in the anterior abdominal wall, which suggested incisional hernia. The first CECT scan reported pyloric thickening, which suspected neoplasm. It also led to the GI and neuro referrals to rule out any other neural case. So another GI endoscopy was done which could not due to which in which the pylorus could not be intubated due to the misalignment caused by the gastric herniation. After that, another repeated CECT scan was done, which had markedly distended stomach with some fluids, but a large supraumbilical hernia which contained the greater curvature, prepyloric antrum, mental fat, which was leading to gastric outlet obstruction. It's visible in the CT scan. You can see that on physical examination, and there were no such signs. Only there were vital signs were stable. In the on physical examination, it was unremarkable. There was swelling at epigastrium along with cholecystectomy incision line, which was reducible with gurgling sound. The lab were almost normal except this serum creatinine, which was deranged a bit due to vomiting and dehydration. There was a mild hyponatremia and hypokalemia also. So, upon with the consultation of the gastroenterology department, a diagnosis was made that led to like gastric outlet obstruction secondary to post-cholecystectomy incisional hernia. This was confirmed after a repeated CECT, clinical correlation, and intraoperative findings. So, now the surgical management. The procedure was started like an upper midline incision. The following things were found in the herniation, that was the greater curvature of stomach, pyloric part, omentum, and transverse colon. There were dense adhesions between the stomach and the hernial sac. Careful adhesiolysis were done, reduction of the herniated stomach and omentum was done, primary closure of the fascia was done, and 15 by 15 centimeter of the polypropylene onlay mesh was placed. Also, closed suction drain was also placed. Post-operatively, the patient was kept nil by mouth for about 24 hours and started fluids on the second post-op day. The symptoms were relieved, the patient was discharged on second day, and there were no recurrences for about 1 month. So now the discussion. The stomach is fixed with the gastrohepatic ligament, gastrosphenic ligament, gastrocolic ligament, and gastrophrenic ligament. Thus, the mobility is limited by such ligaments, but due to age and hormonal changes, these can become weakened and it can lead to the herniation of the stomach. This case is a rare case of gastric outlet obstruction. Often it is confused with peptic ulcer, peptic disease, or malignancy. CT scan is very essential in this case. Endoscopy may fail to identify hernia due to distorted anatomy, and high index of suspicion needed, especially after abdominal surgery. When to repeat CT? When to repeat CT? When the symptom persists, when initial CT is misleading, and when hernia is intermittent or reducible. So the conclusion of this presentation is that the gastric involvement in incisional hernia is extremely rare, but the patient should be considered in patients with persistent vomiting after abdominal surgeries. CT scan plays an important and critical role in the diagnosis of such cases. Endoscopy may become inconclusive when the stomach is herniated, and a surgical reduction with mesh repair offers excellent outcomes. I thank you all. Is there any questions?
Thank you, Doctor, for your wonderful presentation. Any questions from the audience?
Neonatal sepsis is a common pathological process that has a non-cyclical course, is purulent and inflammatory, and is usually triggered by opportunistic pathogenic bacterial flora. According to data reported in the literature, the incidence of sepsis in full-term newborns is approximately 0.1%. Unfortunately, the mortality rate of this disease is quite high and varies between 30 and 40%. Similarly, necrotizing enterocolitis is one of the most serious diseases of the neonatal period and attracts attention with its high mortality rates. The pathogenesis of both diseases is quite complex and involves many organs and systems. The main factor that plays a major role in the development of sepsis in full-term newborns is the dysfunction of the immune system. This condition can lead to multi-tip organ failure with systemic inflammatory response syndrome, purulent infection foci, or bacteremia. Three main pathological processes are at the forefront in the pathogenesis of NEC: hypoxia, mesenteric hypoperfusion, inflammation. These factors play a fundamental role in the formation and progression of the disease. It is characterized by the development of circulatory disorders in the intestinal wall, congestion of vessels in the submucosal layer, widespread hemorrhagic foci, and ischemic necrosis in mucosa. This change occurs as a result of hypoxic damage to the central nervous system and constitutes the characteristic morphological substrate of NEC in the full-term newborns. Differences in the pathogenesis of sepsis and NEC require the application of different clinical approaches and treatment methods of these diseases. However, the complex clinical presentation of these two diseases are quite similar. This similarity makes early diagnosis and differential diagnosis difficult. Therefore, it is of great importance to identify specific biomarkers in order to facilitate the distinction of these diseases and ensure their effective management. There are many approaches to investigate biomarkers for the assessment of organ and system damage during sepsis and NEC. The majority of these biomarkers belong to the group of pro-inflammatory cytokines that are activated during the acute phase of inflammation of infections or autoimmune region. However, since the pathogenesis of both diseases is multifactorial, marker based solely on inflammation indicators cannot fully reflect the pathological process associated with this disease. Many studies have been conducted to identify biomarkers that characterize the pathological process in sepsis and NEC. Conventional hematological tests and acute phase proteins are ineffective in detecting the septic process. Early diagnosis of sepsis and differential diagnosis of severe forms of NEC remains a challenging, as similarity of clinical presentation, complexity of its pathogenesis, and lack of sensitive biomarkers. For this reason, new biomarkers to be developed must be more specific, high sensitivity, while being low cost and easily accessible. These features will enable timely differentiation between sepsis and severe clinical forms of NEC and early diagnosis. In addition, it is of great importance that these biomarkers are not only diagnostic but also explanatory of the pathogenesis of the disease. In cases of sepsis and NEC, the bacterial translocation mechanisms that occur when the gastrointestinal system affected are different from each other. Mesenteric hypoperfusion, which develops due to hypoxemic damage to the central nervous system, causes deterioration of microcirculation in the intestinal wall. The pathogenesis of NEC is characterized by significant circulatory disorders that occur due to dysfunction of the vascular endothelial layer in the intestinal wall. This dysfunction of microcirculation is manifested by the disruption of the balance between the vasoconstrictor and vasodilatator properties of endothelial cells. Vasodilatation occurs with production of nitric oxide in response to vasoconstriction caused by erythropoietin against decrease in cerebral blood circulation due to hypoxia. As a result of vasodilatation, vascular permeability increase, the barrier function of the intestinal walls is impaired, and this leads to bacterial invasion and the emergence of NEC. In sepsis, intestinal infection develops as a result of the spread of the infection due to congenital or acquired immune system deficiency of the newborn. NO plays an important role in the regulation of many physiological reactions in the nervous and immune system and is actively involved in pathological processes such as hypoxia and inflammation. Regulatory mechanisms of NO occur through cellular and vascular response to hypoxia and inflammation. Synthesis of NO by immune and tissue cells occurs through the constitutive nitric oxide synthase enzyme, which has three isoforms: endothelial synthase, inducible synthase, neuronal synthase. During hypoxia, NO produced by endothelial and neuronal synthases affect neurotransmission and leads to the accumulation of calcium ions within the cells. During inflammation, immune and tissue cells, macrophages, fibroblasts, hepatocytes produce NO via endothelial and inducible synthesis. Activation of this enzyme is induced by factors such as pro-inflammatory cytokines, bacterial hypopolysaccharides, and catecholamines. As a result, low levels of NO detected in newborns with sepsis indicates the insufficiency of the immune system. This biomarker can be considered as an important tool in early diagnosis and differential diagnosis of diseases with similar symptoms. Full-term newborns included in the study were admitted to our clinic from maternity hospital in Baku and other regions of Azerbaijan. During hospitalization, medical cards were prepared for each patient containing detailed anamnesis and clinical data, clinical diagnosis, and tests performed. The inclusion criteria for study were the presence of clinical gastrointestinal system, abdominal distension, vomiting with bile, hyperemia and swelling of the anterior abdominal wall or abdominal tenderness, absence of frequent stool, blood in the stool. Other findings were different degrees of impaired consciousness, respiratory failure, cardiovascular failure, mosaic appearance of cyanosis on skin. To conduct this study, we divided the main group into two groups. The first group includes newborn with NEC. Second group include patients with who develop septic complications. And all levels in the blood serum of the newborns were measured by colorimetric methods. Sensitivity and specificity of NO as a predictor in the differential diagnosis of NEC and NEC sepsis were calculated and ROC-curve analysis was applied. ROC analysis was performed considering different biomarker combination. Analysis and statistical processing of the research results were carried out using Python 3, Scleron 0.22 and Scipy 1.6.1. Statistical analysis of the numerical data obtained was carried out using the Mann-Whitney test and ROC-curve analysis. This single-center prospective and retrospective case control study was conducted in Baku, Azerbaijan. It was carried out in the newborn babies intensive care, pediatric surgery, and pathology departments of the Pediatric Scientific Research Institute named after Farajova. The research was conducted between January 2017 and May 2019. In total, according to the Bell classification, patients were diagnosed in stage 1, 53 patients, in stage 2, 29 patients, in stage 3, 18 patients. The gestational age of the newborns varied between 37 and 42 weeks. The birth weight of the children varied between 2,500 and 4,400 grams. Only necrotizing enterocolitis was diagnosed in 83 patients and no septic complications were observed. Septic complications of necrotizing enterocolitis were detected in 17 patients. To investigate this, the analysis patient data according to the stage of the disease, it was revealed that septic complications occurred in 4 newborns with stage 1 NEC. The pregnancies of the mothers of 3 infants with stage 1 NEC complicated by sepsis were associated with intrauterine infection, and 1 infant was diagnosed with meconium ileus. In NEC1 patients, the disease manifested itself with non-specific symptoms, nervous system, cardiac and respiratory system dysfunctions, and gastrointestinal findings, abdominal distension, and vomiting with bile, related to the general toxic effect. Meteorisms and enlargement of the intestinal lobes were observed röntgenographically. Among the second group patients with stage 2 NEC, septic complications were observed in 3 children. In those with stage 3 NEC, sepsis developed in 10 infants. It should be noted that the clinical manifestation of stage 2 NEC and stage 3 NEC and NEC with sepsis show certain similarities. Common symptoms in the clinical pictures of NEC2, NEC3, and NEC sepsis are disorders of consciousness, weakness and adenomia, respiratory failure, fever, abdominal distension, and anterior wall edema, vomiting with bile, irregular defecation. Nevertheless, hypoxic factors predominate in the clinical pictures of patients with stage 2 and stage 3 NEC, particularly involving central nervous system. Intracranial hemorrhage was observed in 15 infants, grade 2 in 3, seizures in 19, severe impairment of consciousness in 15, and congenital cardiovascular malformation in 13, along with respiratory disorders. In patients with neck complicated by sepsis, the specificity of the clinical pictures was characterized by the predominance of infectious manifestation, namely the presence of infection foci and organ system systems, ventriculitis, peritonitis, osteomyelitis, omphalitis, pneumonia. Ventriculitis occurred in 6 infants, osteomyelitis in 4, severe pneumonia in 7, peritonitis in 6, span necrosis in 1, and omphalitis in 1. In this study, the overall mortality rate among neonates with neck was 20.5%, whereas in neck with sepsis, it reached 47%. During the comparison of these indicators of biomarkers in the research groups, an increase in NO-EPO and decrease in calcium ions levels were observed in 83 neck patients. It is noteworthy that in patients with septic complication with neck, NO levels were lower compared to neck 1 and the control group. EPO levels were also lower compared to patients in neck 2 and neck 3, while a small increase in calcium ions levels was observed only compared to neck 3. Considering similarities in the clinical pictures in neck 2 and neck 3 and neck sepsis patients, laboratory data were analyzed in these groups. Mono-Whitney test was applied to detect statistically significant differences in NO-EPO calcium ions levels, and the results are presented in Table 1. Numerical data of serum levels of EPO and calcium ions were also used to plot the ROC curve. ROC analysis was performed separately in neck sepsis patients, considering different combinations of biomarkers. Best cut-off points, specificity and sensitivity were obtained by calculating the area under the curve. In our study, the highest diagnosis value was observed with the use of NO parameters and EPO and calcium ions combinations, especially in full-term newborns in neck 1, 2, and 3 patients. The fact that there is no statistically significant differences in the area under the curve of EPO calcium ion biomarkers and their combination shows that diagnostic and effectiveness of these biomarkers is insufficient. Hence, it can be said that calcium ions parameters should not be used in a differential diagnosis of these two pathologies. Moreover, value of EPO does not have a significant impact on results. In this figure, the area under the curve values were observed with the use of NO. This result reflecting the statistical significance in the differential diagnosis of biomarkers and their combinations in neck 2, neck 3, and neck sepsis patients are presented in Table 2. This figure shows sensitivity and specificity ROC curve of NO in the differential diagnosis of neck and neck sepsis. The result obtained reveals the important role of NO in the early diagnosis of sepsis, allowing these markers to be evaluated as promising biomarkers for the development of timely diagnosis and treatment approaches. Low levels of NO indicate the development of sepsis and will help determine the correct treatment strategy in the face of similar clinical pictures. The lower limit of NO level can be used to create a mathematical formula that will enable early differentiation of sepsis from diseases with similar clinical appearance. When NO level is less 37.8 millimoliters, sepsis may occur. Based on our data, a formula was developed for the early diagnosis of sepsis, and its differential from diseases with similar clinical course based on serum NO level. Through the formula presented below, the process of sepsis can be identified in time. The accuracy rate of the model is 87%. Extremely low values of serum NO can be considered as predictor marker for the early diagnosis of sepsis. Decrease in NO synthesis is an indicator of pathological process, indicates development of sepsis. Of the three markers used, NO is specific biomolecular marker for sepsis. Accordingly, low serum NO level observed in full-term newborns diagnosed with neck sepsis can be considered as indicators of sepsis. Thank you for listening to my presentation. My contact information is below. Hello?
Today, I'm going to present our systematic review and meta-analysis in the question of that is timing matters to evaluate the outcomes of early versus delayed cholecystectomy. Shall we proceed?
Yes, you can.
Okay. This review was based on our review. The study was titled as Outcome of Early versus Delayed Cholecystectomy in Acute Gallstone Pancreatitis, a systematic review and meta-analysis that published by me and my colleagues and supervised by our consultant, Dr. Mohammed Kamran, the general surgery consultant. So, before we start, I'd like to take a few moments to describe our disease, then moving forward. Acute pancreatitis is an inflammatory condition of the pancreas that may lead to severe abdominal pain, necrosis, and organ failure. There are many causes to this disease, but the most common are gallstones and alcohol use. Usually, mild acute pancreatitis or acute gallstone pancreatitis is managed by surgery, mainly by cholecystectomy, to prevent the recurrence of the biliary events. But unfortunately, the optimal timing of the surgery is still controversial because we don't have a solid ground to say we should operate earlier or delayed. So the gap we found in the researches was the timing of the surgery. While some recent evidence suggesting that early cholecystectomy during the initial admission is safe and reduce hospital stay, and other studies confirm also it lowered the risk of recurrent the biliary events and post-op complications. So we aimed to evaluate and compare the outcome of early versus delayed cholecystectomy. We defined early as we operate within the 48 hours since the initial admission of the patients, and delayed was defined as 6 weeks after the recovery and the resolution of the symptoms that was in patient with mild acute gallstone pancreatitis. We focused on two major categories, effectiveness and safety. For the post-op mortality and complication rates was the safety of the patients, and effectiveness was categorized as length of hospital stay and the recurrence of the biliary events. We designed the study as a systematic review and meta-analysis. We followed also PRISMA guidelines to do this review. The data was obtained from Web of Science, PubMed, and Cochrane Library. We include the adult patient diagnosed with mild acute gallstone pancreatitis. We exclude the other severity of the disease like moderately severe and severe pancreatitis. The studies that enrolled in our study must compare early versus delayed cholecystectomy and report our outcomes. We analyzed the data based on risk ratio with bold effect estimate using random effect model. Heterogeneity was assessed using I2 statistics tool. So let's starting with first safety outcome is the post-op mortality, which was nearly 0% in all the studies. with exception for only one case in the delayed group due to a post-op heart failure. The second one was the post-operative complication. The complications were mostly surgical site infections in both groups as an early or delayed group, with one case of bile leakage was reported in early group, 5 cases of atelectasis, and 1 case required blood transfusion. The subgroup analysis of the surgical site infection was significantly, with no significant difference in early or delayed group, with the risk ratio was only 0.96, with the confidence interval was 95%, and the p-value was 0.94, with no heterogeneity observed. The overall post-operative complication, including surgical site infection and non-surgical site infections, like I mentioned before, the bile leakage and the cases of atelectasis and blood transfusion, was also not significantly differ between the two groups, and the risk ratio was 0.78, with the confidence interval was 95%, and p-value was 0.46. There was no significant difference also between the subgroups, and chi-square was 0.26 with a p-value of 0.61. Here I attached the first plot of the analysis. As we can see in the first category, the surgical site infection, a total events was 8 out of the 5 studies we enrolled, and the delayed group only was 11 out of 201. As we can see here, it is not that significantly different. Also, for the non-surgical site infection, there was equal between the two events, between early and delayed groups, with the 6 for both groups, and also wasn't that significant between the groups, and the total was also not significant. For the effectiveness, for the safety of the patient, for the length of hospital stay, was significantly shorter in earlier group, with a mean difference of minus 2.68 days, which mean the delayed group was staying more 3 days, almost 3 days more than the earlier group. The confidence interval was 95%, and the p-value was less than many times. With, unfortunately, moderate heterogeneity was present. The I2 statics was 70%. Here I attached the first plot also for the length of hospital stay. As we can see, it's more favorable for the early group. For the recurrence rate, it's only reported in 4 studies as the recurrent with the pancreatitis. The analysis demonstrated a significant lower recurrence rate in early group. The risk ratio was 0.05, and confidence interval was 95%, with a p-value also. And we don't have any heterogeneity observed. Also here I attached the first plot for the groups, and we can see the recurrent event out of 148 patients enrolled under the early group was 0. But for the delayed group, it was 149 cases, and report only 23 cases with recurrent of the symptoms. For the secondary outcome was the need for ERCP. For studies only report the needs for the ERCP, with no significant difference between the groups. The risk ratio was 0.94, with the confidence interval 95%, with a substantial heterogeneity observed as a 71%, and chi-square was 10.24. Here, the need for ARCP in both groups as a total, for the early group, a total of 134 cases, only reported a 36 case, and out of 158 in delayed group was only report 46 case, and we can see it's not significant difference between the two groups. Now we finished the demonstration of the result, so let's discuss our findings. The early cholecystectomy group showed significant reduction in hospital length of stay, the risk of recurrent pancreatitis, with no increasing post-op complication or mortality, which reinforced the safety and potential benefits of early surgical intervention in mild cases. So we can say if we operate earlier, it will not affect the patient as we delayed the surgery. The second thing is this reviews also support that early cholecystectomy doesn't increase the incidence of post-op complication, including SSI or non-SSI like bile leakage, and can be performed safely. To conclude our findings, we can say early cholecystectomy is more effective than delayed cholecystectomy. Early also and delayed didn't differ in post-op complications, include surgical site infection and the need for ARCB. These findings support the use of early cholecystectomy as a safe and clinically beneficial approach that may lead to improved patient outcomes. Limitations, as every papers in the world, everyone has a limitation. Our limitation was the most included studies were heterogeneous in defining early and delayed because we don't have a solid ground to say early must be like this from like this and delayed must be less than this or more than this. So we tried to define based on the studies, the early as within 48 hours since the initial admission and delayed after 6 weeks the resolution of the symptoms and recovery of the patient. The second limitation was the number of high-quality RCTs, and some outcomes had a small sample size, with some risk of publication bias. And last but not least, results mainly apply to mild acute gallstone pancreatitis. Unfortunately, it's not for the severe cases like moderately severe pancreatitis or severe pancreatitis. Thank you for listening. Feel free to ask questions.
Thank you, Doctor, for your excellent presentation. Any questions from the audience?
The topic of my presentation is to unveil infantile pyknocytosis through means of a case series. The main objectives for my presentation, they revolve around recognizing infantile pyknocytosis in the evaluation of neonatal hemolytic anemia of uncertain etiology, and to review management strategies, outcomes, and also possible complications associated with this condition, and also to highlight a potential association that was noted in the cases that I'm going to present now, in terms of infantile pyknocytosis and congenital cardiac anomalies, and to explore areas of future research in this domain. To begin with, almost 66 years ago, in the year 1959, a rare cause of hemolytic anemia in neonates was described by Tuffy et al., who discovered peculiar red blood cells with these irregular margins and short projections on peripheral blood smear analysis, which they termed as pyknocytes. And since then, infantile pyknocytosis has been recognized to account for almost 10% of neonatal anemia with unidentified etiology. In this presentation, I will unveil 4 cases that talks about the diagnosis of infantile pyknocytosis, highlighting their clinical spectrum and diagnostic approach. In my first case, I have a term female with hemolytic anemia who presented with hemolytic anemia almost at 2 days of age. The hemoglobin was noted to be 13.9 grams per deciliter. The mother's blood group was B positive, baby was O positive, that was negative. And the newborn screening that was done was negative. And we had negative family history of hemoglobinopathies. A blood film that was done showed features of hemolysis and the presence of these irregular hyperdense contracted RBCs suggestive of infantile pyknocytosis and polychromasia as a reaction to hemolysis. Bilirubin in the initial presentation was 10 milligrams, slowly rising to 12.5 at around 105 hours, but even because it was below the phototherapy threshold, the baby was discharged home. Around day 9 of life, this baby came back with bilirubin of 24, requiring intensive phototherapy. Hemoglobin checked at that point showed a drop from 9.3 grams per deciliter to 8.1 grams per deciliter, and thereby requiring PRBC transfusion. And blood film, also done during this encounter, showed features of hemolysis and features of pyknocytosis very similar to the previous presentation. This baby, after requiring phototherapy for almost 6 days, was discharged home. At 4 weeks, we had a second encounter with this baby, but at this point, it was because of respiratory distress in the event of enterovirus bronchiolitis. It was noted that the hemoglobin showed a drop from 6.8 grams per deciliter, requiring PRBC transfusion. At this encounter, we also noted the presence of an incidental systolic murmur. Hepatomegaly, however, no splenomegaly was appreciated. In the event of an incidental systolic murmur, we did one echocardiography, which showed the presence of a large patent ductus arteriosus, an atrial septal defect secundum, and tricuspid regurgitation, and the baby eventually ended up developing features of pulmonary hypertension requiring medical management. After we managed the acute presentation in this baby, follow-up visits done showed stable hemoglobin for age and normal peripheral blood smears. So here you can see the green arrow pointing towards the pycnocytes, which are these hyperdense cells that the presentation has shown, with irregular shaped spiculated cells that was noted in the blood smear analysis. And the echocardiography findings showing a patent ductus arteriosus as well as ASD secundum measuring a diameter of 4 millimeter. Now, what we can infer from this case presentation is that we have a term baby who had hemolytic anemia, not attributed to the known causes of neonatal hemolytic anemia, and hemolysis being significant enough to require transfusion and hyperbilirubinemia requiring phototherapy. And the episode seems to be also triggered by infection. And we also had an incidental cardiac finding with subsequent development of pulmonary hypertension. Keeping this case in mind, when we move on to the next case, this case also showed a very similar clinical trajectory to case 1. Here we have a late preterm who came in with jaundice, starting at the age of 2 days of age, eventually building up to day 5, requiring intensive phototherapy. The baby also had negative family history of hemoglobinopathies, negative workup for hemolytic anemia. And after receiving almost 5 days of phototherapy and being discharged home, day 18, the baby had another comeback, and this time came with jaundice, but in the event of a urinary tract infection. And after being treated for hyperbilirubinemia, we also noticed a drop in anemia, a drop in hemoglobin requiring transfusion, and an incidental finding of cardiac murmur. And no splenomegaly was also noted during this presentation. So as you can see, case 1 and 2 are very similar in terms of their findings that was noted, implying that infantile pycnocytosis can result in recurrent episodes of jaundice, and there seems to be a possible trigger of an underlying infection. And also our incidental cardiac association does lead to some sort of a suspicion of a relationship in between these two conditions, which we will discuss further in the presentation. Moving forward, the 2 cases that I have shown here are actually siblings born to first-degree consanguineous parents who had a very similar clinical trajectory to the first and the second case. They came in with jaundice, treated with phototherapy, requiring transfusions as well. But the only thing that you can see in case 3 that will also further imply about infantile pycnocytosis is that once when the baby in case 3 was discharged after managing hyperbilirubinemia with a bilirubin of 14.7 and a hemoglobin of 7.9 when the baby was discharged home, we noticed that follow-up visits showed hemoglobin levels stable to meet the hemoglobin levels which was appropriate for age. So around 1 month of age, the hemoglobin was 10, and follow-up at 3 years showed a hemoglobin of 11.6. So this shows that both the siblings that is seen in these 2 cases shows that there's probably a potential genetic or a familial component that warrants investigation in this unknown condition. So as we bring all the cases that we have seen so far together to understand what exactly infantile pycnocytosis is, that we see that the etiology of infantile pycnocytosis, despite the fact that it has been something that was in the literature for almost 66 years, the etiology seems to be largely unknown. Familial clustering and recurrence in siblings and twins, as well as recurrent maternal histories of recurrent miscarriages, they raise the suspicion of underlying genetic susceptibility that is probably unmasked by perinatal environmental triggers. And also recent reviews have shown that perinatal events may expose these neonatal red cells to oxidative stress in genetically predisposed infants. But a specific gene or a pathway is not yet identified in these cases. Although the exact pathophysiology of infantile pycnocytosis, it remains poorly understood, there seems to be an hypothesis involving extracorpuscular factors linked to oxidative stress and cellular damage. So a case that was reported by Ackman et al. Showed that the conversion of transfused red blood cells into pycnocytes were observed during an exchange transfusion, suggesting that maybe external factors induce changes in the red blood cell morphology. Also, a cohort study of 16 patients with infantile pycnocytosis showed the presence of Heinz bodies in 50% of newborns and 100% after prolonged incubation for almost 4 hours. Now, Heinz bodies are these dark basophilic inclusion bodies of denatured hemoglobin indicative of oxidative stress. The Heinz bodies, even though normally they can be found in healthy neonates, their presence of 100% of the cases, it correlates with the involvement of oxidative stress in infantile pycnocytosis. Adding to the cases that is reported in this presentation, 2 of the cases that we saw actually had episodes of hemolysis in the event of urinary tract infection and respiratory illnesses, indicating that probably infectious pathogens could exacerbate oxidative damage to the red blood cells. So even though there is no clearly identified hypothesis, the hypothesis of extrinsic factors, as well as there is also another hypothesis of intrinsic factors, could interplay with the pathophysiology of infantile pycnocytosis. Looking at the intrinsic factors, the fact that infantile pycnocytosis is actually a Coombs negative hemolytic anemia, it indicates that hemolysis is not actually immune mediated, as seen in ABO-RH incompatibility. This means that intrinsic factors that affect red blood cell stability could be attributed to this cause. A study that was done by Claire declared that there was reduced levels of glutathione peroxidase enzyme that was noted. Glutathione peroxidase is an enzyme that prevents the RBCs from oxidative damage. The fact that enzyme deficiency was associated with this could mean that intrinsic factors could also be a contribution. So thereby, when exploring the pathophysiology of this condition, it seems to be a complex interaction in between both extrinsic and intrinsic factor, leading to increased RBC fragility and hemolysis. When we move forward to see when are we going to suspect infantile pycnocytosis, it seems that the presentation usually comes within the first few days to weeks of life, as we saw in the previous cases that was presented. Babies usually present with jaundice and anemia, severe enough to require supportive management. It's presented with a Coombs negative anemia and signs of hemolysis. It's a diagnosis of exclusion, and absence of splenomegaly is often typical. The main key test involved in diagnosis infantile pycnocytosis is a peripheral blood smear, which shows more than 5% pycnocytes, which are these small contracted hyperdense cells with spiculated outlines that we have seen in the previous images with the cases. And the proportion of these pycnocytes can increase over the first weeks. They often peak around 3 to 6 weeks, and they gradually disappear by 4 to 6 months as anemia resolves. Now, repeated smears during the follow-up, as seen in the case series, document the transient nature of the pycnocytes and parallel clinical improvement. The 2 of the cases out of the 4 that was presented showed the presence of congenital heart defects that led to the suspicion that maybe the presence of congenital heart defects found in these cases and infantile pycnocytosis could actually be potentially related. Now, case 1 and 2, they share the similarity in terms of having the presence of a 4 millimeter atrial septal defect. While atrial septal defect can occur in 1.6 per thousand live births, the co-occurrence in infantile pycnocytosis, it may not be coincidental. While the literature does not seem to establish a direct causal relationship between this condition and congenital heart defects, the occurrence in the same person, the same patient, could show some sort of a shared risk factor or a developmental anomaly during gestation. Now, some of the congenital heart defects, they have genetic components and a familial predisposition. So similarly to infantile pyknocytosis, also there could be a familial disposition and genetic component. So an interplay between this familial disposition and genetic components could explain their co-occurrence in the affected neonates. In case 1 of our series, we saw that the case actually extended beyond having a cardiac complication, eventually resulting in the development of subsequent pulmonary hypertension. As we sat down to explore what could be a potential explanation for pulmonary hypertension, one of the reasons that we could fairly stress on is the cardiac complication itself. Because having a congenital heart defect can result in increased workload on the right ventricle, and that can result in pulmonary vascular changes leading to pulmonary hypertension. At the same time, the presence of severe anemia in these cases requiring multiple transfusions can actually result in systemic inflammation and oxidative stress response. Pulmonary hypertension from these hematological disorders can arise either from pre-capillary causes or post-capillary causes, or as a combination of both. If you go to see in intravascular hemolysis, it releases free hemoglobin and arginase 1. Now, both of them, they work in different mechanisms to decrease the level of nitric oxide. Nitric oxide, as we all know, is a potent vasodilator, but it's also a regulator of endothelial cell proliferation and an anti-inflammatory agent. A decrease in nitric oxide would just mean there's impaired vascular endothelial function, and that can result in pre-capillary pulmonary hypertension. Also, given the fact that there is chronic anemia in these cases, at least for the first 6 months of life, 4 to 6 months of life, this high cardiac output state would mean that the left heart disease and left ventricular dysfunction could result in post-pulmonary pulmonary hypertension. Also, having hemolysis in chronic anemia can induce oxidative damage to tissues, which will activate platelets, coagulation cascade, eventually leading to hypercoagulopathy and DVT and pulmonary embolism. All of this could serve as a potential risk factor for pulmonary hypertension. So this basically implies that infants who have severe hemolytic anemia should actually be screened for pulmonary hypertension, particularly when cardiac defects are present. Moving forward, the management of infantile pyknocytosis is majorly, it is supportive. We can give phototherapy in terms of hyperbilirubinemia. Anemia is treated with PRBC transfusions. Some of the reports have shown promising results with recombinant human erythropoietin. As seen in the cases that we have presented here, early intervention with phototherapy and transfusion actually leads to favorable outcome. And this is something that was also noted with the cases presented in this presentation. The prognosis is often it's self-limiting with 4 to 6 months of age. No long-term complications are actually seen if they don't have any underlying pathology. Infants, they return to normal health. Normal hemoglobin levels as well as blood smear analysis are normal following their spontaneous resolution. And this is evident in the follow-up evidences from this case series in case 1 and case 3. The potential complications, if it's left untreated or severe, could include pulmonary hypertension in the event of a cardiac defect, especially cardiovascular strain because of severe anemia, kernicterus because of prolonged jaundice, elevated bilirubin, and neurological deficits can also be seen in severe hyperbilirubinemia. So this takes me to the final slide of my presentation, where I want everyone to draw a key takeaway from this fairly unknown condition. Recognition seems to be very important in infantile pyknocytosis. You can suspect it, especially when you're presented with a newborn with jaundice and anemia occurring in the first few days to life, to weeks to life, Coombs negative anemia especially. Diagnostic approach is by looking at a peripheral blood smear that shows more than 5% pyknocytes, which are these irregular hyperdense spiculated cells, and other causes, ruling out other common causes of hemolytic anemia such as ABO-RH incompatibility, G6PD hereditary spherocytosis. Comprehensive evaluation seems to be important, especially when the child is presenting with cardiac defects. There seems to be some familial patterns that is so far established. And timely management with phototherapy, symptomatic management with RBC transfusions, all of them seem to be improving the outcome in neonates treated. The prognosis seems to be self-limiting and with no recurrence beyond infantile period. Given all of these things, all of these information that is currently present in this era, anyways, moving forward, we notice that there is future research needs in this domain, especially in elucidating the pathophysiology and genetic factors, establishing some kind of a standardized diagnostic criteria, and to also look into further investigations regarding the relationship between cardiac defects and pulmonary hypertension associated with infantile pyknocytosis. So my final message is to increase the awareness among healthcare providers regarding infantile pyknocytosis for early identification and appropriate management. And these are my references. And special acknowledgements to my consultant pediatrician, Dr. Sura Ahmed, working at Al Jalila Children's Specialty Hospital, and Dr. Mahmoud Hussain, who's a consultant pediatrician at Hatta Hospital, Dubai. Thank you very much.
Thank you, Doctor, for your wonderful presentation.
Thank you.
Any questions from the audience?
Rwanda Cancer Registry, a 5 years report on cancer incidence, diagnosis, and application for intervention. This is it is our country, Rwanda. It's a country located in East Africa. It has the population of 13 million population. It has 5 provinces, and the cancer diagnosis. It has 5 cancer diagnosis and treatment centers. This is our health system structure. I'm not going to take a little bit about this. And let me talk a little bit about the background or evolution of the cancer registration system in Rwanda. The Rwanda Cancer Registry has started in 1994, and it was population-based cancer registry. And again, it has stopped in 1994 due to genocide against the Tutsi. It resumed in 2010, but it faced different interruptions. It is from 2018 that the cancer registry has been part of Ministry of Health, which made it to be sustainable from that time until now. So the data collection method was a manual data collection from the beginning of the registry, and the data entry was done into Canreg 5 software. This is a WHO tool for cancer registration. However, it is a desktop-based application. This was a resource intensive and require significant human effort for case finding and data entry. It is from 2019 that the cancer registry has been integrated into DHS2. DHS2, it is District Health Information System, which is a health surveillance system for most of African countries for automated data collection. The integration of cancer registry into DHS2 enabled real-time high quality of data, broader coverage, and again, sustainability and integration into MOH surveillance system. Actually, we can see like the population of our country. Our cancer registry, it is a population-based cancer registry, and it is located at RBC under Ministry of Health. It has 4 staff and at head office and 5 patient navigators. Those are healthcare providers based in the cancer centers, helping in the navigation of patients to ensure that all patients are receiving treatment, diagnosis and treatment, but also they are supporting into cancer registration, cancer case finding, and the data entry into cancer registry. The registry has an advisory committee made by 17 members, which are oncologists, epidemiologists, researchers, epidemicians, and so on. This is a team which have helped like the cancer registry in the advisory role. Looking at the source of information for our cancer registry, Rwanda, we have mainly cancer diagnosis and treatment center 5. So data collection is being done into mainly those cancer centers, but you have also private hospital and clinics, laboratory 23, which are also source of information for cancer registry. And you have vital statistics, which is like the office recording data on death, And again, you have district hospitals. Those district hospitals, they're not primary managing cancers, but they can make some primary case findings and referral and follow-up of palliative care. They're also source of information for our cancer registry. The methodology of data collection for the cancer registry, actually in different cancer centers, district hospitals and hospitals, we have cancer registry focal person, which have the role of identifying cancer patients through patient file or MRI systems. And again, they do data entry into DHIS2 oncology tracker. As I mentioned before, DHIS2 is like a health MOH health surveillance system where those cancer registry do direct data entry into this system. They do coding using ICD-03. And again, they update records when for new cases and for old cases. And again, at cancer centers at RBC, which is part of MOH, we have cancer registry people staff who validate data. I wanted to emphasize that this is a web-based system. So cancer registrars make data collection within their respective hospitals, private clinics, and hospitals. At central level at RBC, our role is to check the data into the system, validate data, make data quality check, provide technical support and supervision and mentorship. Once the data is into our DHIS2 system, we do importation of data into Canrig 5 software. This is a software which has been developed by WHO through IARC, International Association for Research on Cancer. This tool help to make like advanced analysis and report according to international standards. And this Canrig 5 software, it's a tool used in all African countries, some Asian countries, Caribbean. I think it is the most population-based cancer registry tool used into different different countries worldwide. What is DHIS2 in summary? As I have mentioned, the DHIS2 is a pen source digital platform for health data management. It helps to correct, manage, and analyze and visualize the data. It supports facility reporting, surveillance, and program monitoring. It can be customized into multiple programs like HIV, cancer, etc. It has been developed and maintained by University of Oslo, but it is used in more than 80 countries across the world, mostly in Africa and South America and Asia. But in most of the country, it is used for reporting just aggregated statistics, such as number of cases, number of deaths, etc. But some countries have customized to as individual program. So Rwanda has been the first country in the world that was able to customize the cancer registry according to international standards for cancer registration into DHIS2. And this has been a key for sustainability of the registry. And again, some countries across Africa are learning from Rwanda experience, like Kenya, Tanzania, Nigeria, Benin, and a country in Caribbean. They're learning from Rwanda experience to integrate also cancer registry into their DHIS2 so that they can have like a web-based source of data having real information for cancer surveillance within their countries. If you look at the results, this graph show the results from our Rwanda Cancer Registry from 2007 up to 2014, 2024. If you can look at those data, you can see that in 2007 we have low incidence because at this time Rwanda was having only one pathologist and one cancer centers. Most of our cases were not diagnosed and reported. But as you can see, the last year of reporting, 2023, you can see the number of new cases that have been registered. These have been is due to improvement in diagnosis capacity, treatment capacity, but as well as cancer registration system that has been improved mostly in those past 5 years, where you can see that the number of cases has been high compared to previous years. If you look at the top 10 cancers that we have, breast cancer is a leading cause of cancer morbidity in Rwanda, followed by cervical cancer. We have also prostate cancer, stomach cancer, liver cancer, colorectal, leukemia, lymphoma, etc. Those are the number of cases that have been registered into our National Cancer Registry from 2019 up to 2023. If you look at the distribution of cancer cases by age, you can see that in male, you can see that in male, this red color represents like the age group with high cases, while it is also similar in this age group of female. If you look at the top 10 cancer cases in 2023, you can see that again, breast cancer is coming at the first position, followed by cervical cancer, prostate cancer, and stomach cancers. Okay, this show the top 10 childhood cancers that have been registered during this period from 2019 to 2023. You can see that in children, the leading cancer is leukemia, where you can see also these numbers by age category. You have lymphoma, we have central nervous system neoplasma, you have also neuroblastoma. You can see that those are the number of cases. On the right side, you can see the age standardized rate of those cancers. You can see that leukemia is on the top, lymphoma, and so on. So we have also some key achievement. Our cancer registry is used for different purposes. It is used to help policy planning. It has been used in development of one national cancer control plan and the Ministry of Health strategic plan and the strategic plan and the national cancer registration. Our cancer registry also has been used by different countries. It is also data as a helping for patient navigation system. We have also a patient navigation system launched in 2023. We have also a national childhood cancer registry launched in 2024. If you can see evidence to policy practice, our registry is used for MOH annual report, cancer medicine quantification. It's used for also mission 2027 and again CBHI coverage and different policy brief. We have also many different research that have been made using the data from our National Cancer Registry. Those are like some publications done using data from our registry. Sometimes the registry is facing different challenges like poor documentation, where sometimes staging information are missing, demographic information treatment. Sometimes health facilities are not owning the registry. This require as Ministry of Health to send staff to be helping health facilities. We have sometimes healthcare providers in charge of cancer registry who are having like different responsibilities. And again, we have identified that some health facilities are using different AMR systems, and the interoperability between those AMR system and our DHS2 cancer registry is not yet done. And again, most of the time we are facing sufficient budget for cancer registry operations. So we have our registry have different projects in a pipeline that will be helping our registry to improve. First of all, we have established a center for DHS2 training with the support of African Cancer Registry Network, the International Association for Research on Cancer and Vital Strategy, so that countries wishing to use the system can be trained within our registry, do the visit, experience sharing, and so on. And again, we have started the project of integration of our cancer registry into different AMR systems being used in different hospitals for automated data collection. We are doing also data quality completeness, and again, we're working to link our registry within mortality linkage. I mean, within a mortality database. And again, Verbal autopsy, it is a new system that is used in health facility to identify cause of death not reported by health facilities. As you know, unlike USA, Europe, where all deaths are certified by doctors, in our countries, we have a shortage of medical doctors, and some deaths are occurring out of health facilities where there is no certification of death by doctor. So we have established an automated system available to see, which is helping to take like data on death occurring after health facilities and not medically certified, and they were aiming to link those data into our register so that you can have like the completeness of data on death. We have also launched the mission 2027 of cervical cancer elimination, where Rwanda is aiming to achieve global strategy of cervical cancer elimination by 2027. And the cancer registry is helping a lot, and we are having a project of link our cancer registry into our cervical cancer elimination EMR. And okay. Thank you. Those are the key staff working in our cancer registry, and thank you for our partners, especially Vital Strategy, which is helping a lot, African Cancer Registry Network, and again, other partners that are helping to make sure that our registry is very working. Thank you. This is the end of my presentation. This is my contact email, so that anyone willing to collaborate with us, either in the registration system, either in research. Actually, Rwanda Biomedical Center is a hub for research for Africa. If anyone is willing to work with us for different research related to cancer incidence, mortality, survival, etc., you are most welcome. Thank you. Over. This is the end of my presentation.
Thank you, Doctor, for your excellent presentation. Any questions from the audience?
The barrier workforce-driven innovation in healthcare. It was published in 2024. In this presentation, I will discuss the healthcare workforce, including nurses, physicians, and allied health professionals, that plays a central role in driving innovation within clinical setting, yet continue to face several multi-level barriers that limit their capacity to lead to meaningful change. I'll outline the main categories barrier, identify the literature, examine also the impact on organization and clinical outcome. And I will highlight the practical strategy to address them through the effective leadership, education, governance, and support institutional framework. I hope this session will contribute meaningful to how we can strengthen innovation capacity across the healthcare setting and advance patient outcome through more empowered and engaged workforce. So innovation is foundation in healthcare improvement, from clinical procedures to the patient safety system. Healthcare workforce play a central role in generating and implementing.
Dr. Ella, sorry to interrupt. Could you please present it in slideshow mode? Yeah, now it's perfect.
It's the workforce plays the central role in developing and implementing a new idea. However, the innovation effort can be hidden by multiple level barrier that we will discuss about. So the background for the innovation, it's enhance the care of quality, efficiency, and sustainability. The workforce engagement in innovation that promote the continuous improvement, the barriers that could lead to stagnation and reduce the organizational adaptability. The aim for this review was for three main ideas. First, to identify the categories barrier, and examine the impact and to provide the strategy for the innovation in healthcare setting. So the concept has been discussed in this review was the employee initiate the improvement in the practice and realize the bottom-up knowledge for the frontline nurses or the bedside healthcare providers and their experience. And the leadership should encourage, participate, creativity, and share responsibilities. The methodology has been done for the review has been done from 2014 until 2024. Although there is no framework has been conducting in that time, but this is the main trend has been discussed. Okay, let's start with the organizational barrier. This is a very important barrier, actually. The rigid hierarchical structure and the bureaucratic decision-making process, the top-down management decisions, that also the lack of financial and support and limited recognition. These all contain from the organization barrier. If we will move to more the human center, like culture and leadership barrier, like if the employee they have resistance or the leadership resistant to change. Also leadership focus on control, not empowering the staff nurses or the healthcare provider, lack of psychological safety, the fear from the employee itself for criticism or ignorance, and minimal recognition for sure. For the individual professional barrier, actually, it's like we know that the healthcare provider have heavy workload and time pressure. Sometimes they don't have even time for taking breaks. What about for their continuous improvement in the leadership, in the innovation skill, limited training, innovation skill, lack of confidence, and professional soul is limiting on collaboration. For the communication, like between the departments, frequent communication between the units, and we know that it's in our healthcare culture, lack of interdepartmental coordination or weak external collaboration network. If we will go for the technology and system barrier, it's also is very important barrier that we should discuss today about the outdated information system, poor digital literacy among the staff, inadequate integration of clinical and administrative data. For the policy and structure barrier, absence of innovation policies, rigid framework, and limited financial. So what is the impact for the barrier in innovation healthcare outcome? It's decline in innovation capacity, reduce the staff motivation and engagement, lower the patient safety and care quality, organizational stagnation. So the strategies that we should overcome this barrier: promote innovation-friendly organization culture, provide financial and administrative support, encourage the staff in participation in the decision-making, recognize and reward the innovation contribution. What about the role of the leadership? The leadership should shift from control to empower the staff, encourage their experimentation on learning from failure, foster the psychological safety and trust, and model innovative behavior. The role of organization: create a formal innovation unit or committee, which is I'm suggesting that, establish transparent communication channel, offer mentorship, also integrate the innovation into institutional strategic goals. For the recommendation for the education and training, integrate the innovation education across all mental science programs. Also for undergrad, if we can integrate that and teaching them how to have innovation skills, and provide continuous professional development in creativity and design thinking, encourage the interdisciplinary workshop and research projects. If we will think about the role for technology, we should invest in modern digital platforms, improve the data integration and analytic capacity, and utilize the technology to enhance the communication and collaboration. The role of the policy and governance, develop institutional policy and link innovation matrix to performance evaluation, and ensure the alignment with the national health care transformation strategies. So the impact the barrier for the staff, the frontline staff itself, it will reduce their motivation and job satisfaction, increase their turnover intention, which is we doesn't want it, and decline their commitment for the creativity. So mainly it's also there is impact for the patient outcome, decrease the quality and safety, decrease the patient satisfaction and trust, slower adaptation, and new evidence-based practice. Actually, the recommendation for future research direction, explore measurable indicator for innovation capacity, also study the link between the innovation and clinical outcome, and if we can, evaluate the intervention for promoting innovation culture. For the practical recommendation, empower the staff through autonomy and shared governance, allow the protective innovation time, reward the creativity and collaboration achievement, embedded innovation goals with the quality framework. So this is the conclusion. Workforce-driven innovation is vital for healthcare evolution. Empowerment and leadership are key factors. Barriers with the multi-level organization, culture, individual, and sustainable innovation ensure better than a strong system. Thank you so much for your attention.
Thank you, Dr. Ala Ibrahim Al Salim, for your presentation. So, any questions from the audience for Dr. Ala?
This case was quite significant in our hospital, especially in recent times, as these medications have gained wider use and they often mask the progressing metabolic emergency. So before I get into the case itself, I'm just going to talk really quickly about why this topic matters. First of all, euglycemic DKA, because of the way it works, it's frequently missed because of the normal glucose, which gives false reassurance. It doesn't really follow the traditional pattern of marked hyperglycemia, which we see in diabetic ketoacidosis, and this directly relates to the SGLT2 inhibitors usage increasing due to the rapid global adoption. As you can see in the graph on the right side, in 2015, we used to have only 1 case per 100. Over the past 10 years, it has increased to more than 10-folds, especially in the Middle Eastern region. These atypical presentations, they led to delayed treatment, and the consequences lead to severe acidosis despite the stable sugars that we see when the patient first presents. So our patient is a 53-year-old female, and sorry, just give me a second. She's a 53-year-old female with long-standing type 2 diabetes. As I mentioned earlier, she was recently switched from basal bolus insulin to multiple oral agents, including empagliflozin, which is the SGLT2 inhibitor in this case. She also had 1-month history of fatigue, nausea, reduced appetite, and 7 kilograms of unintentional weight loss. As for the clinical timeline of what happened, it was over 2 months leading up to the presentation. There was a clear sequence of changes that pushed our patient towards the metabolic decompensation. First of all, her basal bolus insulin was stopped abruptly and discontinued and replaced with the multiple oral agents that I mentioned, which were empagliflozin and also the SGLT2 inhibitor. And 1 month prior to her presentation, she started developing the symptoms of fatigue, nausea, the non-specific vague symptoms that you usually see with DKA. 3 to 4 weeks prior to presentation, she started having reduced oral intake and an appetite, and eventually 7 kilograms weight loss, of course unintentional. Throughout this entire period, there was no infection, no recent illness, or any other reason to explain her decline. By the day of presentation, the symptoms had progressed to the point where she had to present to the emergency room. So what's significant in this case? The medication change specifically. It was the pivotal risk factor in this case. It alone created the environment for the EU DKA to develop. She had been on a basal bolus insulin for years, and it was stopped abruptly without erasing her metabolic reserve. At the same time, she was started on the empagliflozin along with the oral agents. We don't have proper documentation from the patient explaining the reasoning why her insulin was discontinued. It's possible her primary physician assumed she had enough endogenous insulin from her HbA1c of 9%, or they may have believed transitioning her to oral agents would simplify her regimen. There might have been a concern for hypoglycemia, but there was no objective reassessment, so stopping her insulin was unsafe practice. Along with the addition of the glimepiride metformin and the pioglitazone, stopping her insulin was what led to the culprit. So in the emergency, her vital signs were reassuring. She was hemodynamically stable, alert, conscious. Examination was normal in terms of palpation and auscultation. There were no signs of ketotic breathing or respiratory distress, and nothing in her assessment suggested a metabolic emergency, which is exactly why euglycemic DKA is so oftenly overlooked. Once we did the labs, however, it immediately revealed a key abnormality. Although she had a near normal glucose of 7, she had a high anion gap metabolic acidosis with a pH of 7.3, and the bicarbonate was 15. Both the serum and urine ketones were strongly positive, and her potassium was already at the lower limit. Together, this pattern of the normal glucose with marked acidosis and ketosis is classic for what we see in euglycemic decay. So based on the biochemical profile, the clinical context, we made the diagnosis of the euglycemic diabetic acidosis. This occurred, again, as I mentioned, with the abrupt withdrawal of insulin, while taking an SGLT2 inhibitor, and no other precipitating illness identified. My colleague Dr. Ali will later discuss the diagnostic criteria in details. As for her management, of course, this followed the usual diabetic ketoacidosis management. We started her on fluids, and then we started her on the low-dose insulin infusion to suppress the ketogenesis and gradually correct the acidosis. Potassium was replaced as needed immediately at the beginning as the levels were low upon admission. Glucose and electrolytes were monitored hourly to guide the insulin rate adjustments and potassium replacements safely and without any further delay. And of course, all oral antihyperglycemics were withheld and stopped on admission to remove the contributing pharmacological factors. As for the course of the patient, the acidosis gradually corrected over 24 to 48 hours, ketones steadily declined, and her potassium normalized with replacement. Glucose remained stable throughout the admission because we used a dextrose insulin combination, and her symptoms improved noticeably within the first day. Her acidosis resolved completely within the time of admission, ketones cleared, and she became clinically well. She was transitioned back to a basal bolus insulin regimen, and her oral agents were discontinued. She was discharged safely with diabetic education and instruction to avoid SGLT2 inhibitors further on. My colleague Dr. Ali will now take you through just a quick overview of euglycemic DKA, the definition, pathophysiology, and the management as well.
Good morning, everyone. So this is Dr. Ali Al-Hmeigani, also a resident in internal medicine in King Hamad American Mission Hospital, and I'll be speaking about the other half of this presentation. So, what is euglycemic DKA? So, euglycemic DKA is a variant of DKA when glucose is usually near normal, which is less than 13.9 millimole per liter or 250 milligram per deciliter. So, ketonemia with metabolic acidosis despite near normal glucose. It is highly associated with SGLT2 inhibitors, insulin deficiency, fasting, and sometimes in pregnancy as well. So the classical DKA usually comes with elevated glucose, ketone elevation, and acidosis, while in the euglycemic DKA we will have normal or near normal glucose or mildly elevated. Again, we will have ketone bodies and we will have acidosis as well. So the pathophysiology of euglycemic DKA, the core mechanism is having less insulin, high glucagon, and this facilitates lipolysis and ketogenesis. Glucosuria, this is because of the SGLT2 inhibitor itself. So that's why we will be having normal glucose despite worsening acidosis because of the medication itself. Okay, 1 second. Reduced renal ketones clearance. Okay, and this is a graph also that shows you the cycle of the euglycemic DKA. Euglycemic DKA, you will have the SGLT2 inhibitors having glucosuria. This is why in these patients we are having a maintained glucose level. Sorry. Okay. Decreasing insulin facilitates lipolysis and forming ketones, and therefore this is the cycle of the vicious cycle of euglycemic DKA. Okay, so clinically, euglycemic DKA tends to present with vague and non-specific symptoms rather than the dramatic picture seen in classical DKA. The absence of hyperglycemia is exactly what delays the recognition. Without the high glucose to trigger suspicion, the focus tends to shift away from DKA and the diagnosis is frequently delayed. As highlighted in the American Diabetes Association and the European Society guidelines, euglycemic DKA may develop without a clear precipitating illness, unlike the classical DKA. Okay, across the American Diabetes Association and several guidelines, euglycemic DKA can be diagnosed based on the following. So, is when glucose is less than 13.9, as we have already said, acid base, the pH of less than 7.3, and bicarb less than 18 with a high anion gap, ketone positive in the serum or positive ketones in the urine, and therefore a diagnosis of euglycemic DKA can be made. So the management of euglycemic DKA follows the same core principles of classical DKA with a few key modifications due to the normal glucose. So the ADA recommends immediate fluid resuscitation and starts of insulin infusion regardless of glucose level, paired with dextrose when glucose falls below 14 to avoid hypoglycemia. Medication are also stopped and insulin requirement is studied for any chance to be reintroduced. These steps align with the GBDS, AACE, Endocrine Society, and the FDA guidelines. Okay, so there are several lessons that can be made from this case. First and foremost is that normal glucose does not exclude a DKA, and you must always keep euglycemic DKA as a consideration. Secondly, insulin withdrawal must be studied on a patient-by-patient basis and to determine which patient will have adequate control on only oral agents. Thirdly, early VBGs and labs can prevent diagnostic delays, and euglycemic DKA can arise without any precipitating illness, as we've already said, particularly when medication creates an unbalanced metabolic environment. In conclusion, okay, sorry. In conclusion, euglycemic DKA remains clinically significant but easily overlooked emergency. It is subtle presentation, Its subtle presentation leads to delayed recognition unless the physician is actively considering it. Careful evaluation and guideline-based management remain the cornerstone of how we treat our patient, and we must use them as fundamental in our practice in order to prevent harm and ensure safe patient care. And by this ends our presentation. Thank you, everyone. Any questions?
Thank you, Doctor, for your wonderful presentation. Any questions from the audience?
A epidemiology study, a cohort study about Proteus mirabilis infection in ICU patients. So I'm going to talk more about the prevalence and the risk factors and what to expect about bloodstream infections, especially in critical care patients. So Proteus mirabilis is an emerging and underdiagnosed cause of the bloodstream infections in ICU patients, especially in immunocompromised patients. And however, it's still underdiagnosed, and its clinical importance, it has a huge clinical importance, and that's why we decided to do this epidemiology paper. And we're hopeful that more people will be collecting data regarding this infection, and based on it, local guidelines will be able to emerge and treat the critical care patients more effectively. So for the study design, it was a retrospective cross-sectional study. It was the time period where we collected the data was between January and December 2024. We included everyone with a positive blood culture of mirabilis infection. However, we excluded anyone with polymicrobial infections and patients under the age of 18, because if there is polymicrobial infection or anyone under the age of 18, these would be co-founder factors that could affect our results. The statistical analysis and regression modeling using the SPSS and Python. The sample size was around 30 patients. In these 30 patients, we found that 53.3% of the patients had the bloodstream infections and the Proteus mirabilis bloodstream infection, and 56.7% of the infections are hospital-acquired. It was mainly due to the urinary catheterization, 63.3%, 60% due to the central line use, and 60% ventilator support. So it was mostly due to invasive procedures. The risk factors for prolonged ICU stays included central line placement, hospital-acquired infections, and diabetes. So if a patient had any central line placement, it would increase on average their hospital stay by 3.24 days. As for a hospital-acquired infection, it would increase by 2.46, and diabetes, 1 more day in the hospital. In conclusion, the Proteus mirabilis occurred in more than 50% of the hospitalized patient. It was more commonly associated with the urinary catheterization, ventilator use, and central lines. The central line associated infection is a key risk factor of prolonged ICU stay. And our future expectations is to collect more data because, of course, our sample size was very small. It was only 30 patients. So we're hoping to collect even more data and analyze it to create a local epidemiological data and assess the resistant patterns, and maybe by that refining the infection control policies and optimizing the empirical use of antibiotics, which would then reduce infection-related morbidity and mortality in the ICU. This is the paper and the QR code if anyone would like to scan it just to read more about the paper. It's an epidemiology study, so it's straightforward. We were just looking for the risk factors, the prevalence, and how could we proceed next with the empirical use of antibiotics in the treatment plan. Thank you. Does anyone have any questions?
Thank you, Doctor, for your excellent presentation.
Thank you.
Any questions from the audience?
So just a quick introduction about why stent documentation matters. So ureteric stents are vital tools in managing ureteric stones and other urological conditions. And missing these stents, they should come out at a certain period of time. And if we miss them, there is an increased chance of severe complications such as infections, incrustations, and renal damage. So particularly, incrustation means that the stone forms on top of the stent, which makes them very difficult to take out, and they will require complex and prolonged surgery, which will further increase the chances of infection and other morbidity and mortality of patients. So according to the guidance from the British Association of Urological Surgeons, the recommendation is 100% documentation compliance to ensure patient safety. So just to make people familiar, for those who are not familiar with ureteric stents, this is a ureteric stent with two coils, an upper coil and a lower coil. This upper coil coils in the kidney or the renal pelvis, and this lower coil coils in the bladder. And if you see these small openings, this stent is fenestrated throughout its length, bypassing any obstructing stone. Imagine if there is an obstructing stone here, the urine goes into these fenestrations and bypass the level of the obstruction. And this is how it looks inside the body, upper coil in the kidney and lower coil in the bladder. So our objectives in this audit were to compare the documentation of ureteric stents before and after launching the electronic database. So on the 20th of March 2024, we launched a new online stent database. Before that, we used to do that in a paper notebook where many mistakes were made and many forgotten stents happened before implementation of that. And this is why the idea of the new electronic system came. And it took us a lot of work and money to do this, and to buy the system and to put policies in place. Second objective is to assess the effectiveness on the online stent database system. So this audit is two cycles. In the first cycle, we compared the documentation using the paper notebook versus the documentation using the electronic database. In the second audit, there was no more paper notebook. We just tested the effectiveness of the online stent database. And our goal is to achieve and sustain 100% compliance with ureteric stent documentation with the BAUS standards, because this is a disaster for patients. If you miss their stents, you're giving them a terrible time. So the first audit, the initial audit, it was a retrospective audit that has taken place auditing the period from January to May 2024. Remember, the database was launched in March 24. So we had 2 months before the online database and 2 months after the database. And the data was collected from the paper stent books, theater codes, and the operation notes, in addition to the online stent database. Our sample size was 123 patients who had ureteric stent documentations, ureteric stent insertions in this period from January to May 2024. So the results in the first, so surprisingly, the documentation in the paper stent book was 97%, with only 2.9% of stents forgotten or misdocumented. The documentation using the online stent database in the early phase, the first 2 months after implementation, was equally, it was 97.1, which is equal to this. And this was very surprising and shocking to us, because we expected, we said that there is no point of doing the electronic database when they miss the similar number to the paper stent book. So we did a bit of digging and to find out the reasons why this will come in the next few slides. So the missed entries raised our concern for compliance and safety risks. Then we identified the challenges. So the paper book did miss some stent cases as expected, but the omissions from the database were not expected despite proper coding. So one of the things that we have introduced our theater system is that whenever you type the word stent in the operation name and you put the code for JJ stent, it comes with an automatic trigger to document the stent insertion and to when the stent is coming out. So everything was coded correctly, so there was no problem with coding. But when we did more and more, we found that human factors and staff unfamiliarity with the new tool happened and led to this to the stent database missing some stents. So we made some interventions. We have run a training for all the staff, especially the bank staff who are temporary staff, for people who are not in the UK. Bank staff are temporary staff and new joiners. We have also posted small posters like visual reminders in theaters next to the workstation, so that the scrub nurse or the person in charge can always remember to document the stent. So then we have done a re-audit earlier this year from between March and April 2025. And we exclusively tested the online stent database, as the paper notebook does not exist anymore. The sample size was smaller this time, and it was only 34 patients who had uteric stent insertions. And again, this was cross-checked against the operation notes, theater coding. So the results this time, fortunately, we achieved 100% documentation compliance. Each and every patient who had a stent in this given period had their stent documented. And by this, we have demonstrated the effectiveness of training and raising awareness. And there were no omissions or missing data detected. So just a quick comparison. So the initial audit, the online stent database showed 97.1% compliance, and in the re-audit it showed 100% compliance. And as I said earlier, there was nothing wrong with the technology, but these changes and this improvement was mainly driven by education and the cultural shift of people from the paper book to the online stent database. So conclusions and lessons to take home from today. So never trust technology on its own. You have to be on top of things. So digital tools need human consistency and accountability. Structured audits drive sustainable change. You don't just set up a system and just run away. You need to be monitoring and auditing that system continuously to make sure that it's running smoothly. So simple actions like training and reminders yield impactful results. So our future recommendations to maintain compliance through periodic re-audits, and we're planning to re-audit this on a 6-monthly basis just to make sure that we are on the right track. And we have a solid plan to incorporate this STEM database training into the staff who are related to the urology department or the surgical departments into their induction package. So everyone will have this training on their first day when they join our hospital. And then finally, to embed a culture of safety and documentation awareness among all staff. Thank you very much. This was my presentation today. I'm happy to receive any questions.
Thank you, Doctor, for your wonderful presentation. Any questions from the audience?
A comprehensive overview of the spontaneous adverse drug reaction reports are collected in the article. Objective: investigate the trend of spontaneous reporting of anti-COVID-19 vaccines related ADRs collected in Veneto between 27th of December 2020 to 21st of May 2021. Spontaneous reporting. All anti-COVID-19 vaccines-related ADRs, whether serious or not, are reported through the National Spontaneous Reporting System, which represent one of the most important tools for the post-marketing surveillance of ADRs caused by drug and vaccines. Methods: use of descriptive statistics methods, analysis plan. Data were processed according to a specific analysis plan. Data source and development of working project. Data filters are used to extract information which constantly identify the geographical area of interests, in this case Veneto region of Italy, in the period of interests, in this case from 27 December 2020 to 21st May 2021. Following the point listed in the box, the sensitive data of spontaneous reports were obtained by extracting them with VG-SAIN for the period under analysis. DigiSign is an extremely innovative IT platform that the Veneto Regional Center of Pharmacovigilance has developed to allow operators to extract complex data from the database. From the data observed, it is evident that there are brands with higher reporting rate than others, as in the case of community of Bacteria. This partially reflects the different authorization rates granted by regulatory agencies. Discussion. The basic idea in this work is that even in a limited temporal context, should be possible to detect characteristics common to the different types of the scene, analyzing demographic characteristics such as age or sex, or clinical and medical aspects related to severity, the body concern, or the outcomes. The higher reporting rate of women compared to men, common to all brands, is surprising. The percentages of discord are so significant that it cannot be explained by physiological aspects. This data leads to hypothesize possible genetic gender correlations. From investigation of age, surprisingly elderly who have been vaccines earlier and therefore currently with higher number of doses reported only for 10.25%. The present work with the use of descriptive and observational statistics methodologies examined a considerable number of data coming from spontaneous reports following a specific analysis plan, which led to interesting and relevant hypotheses, data relating to the age of patients, gender, or severity of the reaction observed, or organs concerned, or the outcomes can be further investigated to evaluate the hypothesis in the target studies.
Next, I
frequent use with the Botox, patient develops certain complication at any time. So that's why I think it's a very important case. So I have publication on it as well, but let's focus on that. So what happened, as you know, that is Botox has been common recently, and we have seen certain patient. It's very unfortunate. We have seen other patient as well, but we commonly now see in the UK as well, especially when they are using unregulated products. So we see this certain patient develop complication. So this case happened recently. The background of, let's focus on the background. So botulism toxin is safe when administered by a trained clinician and using regulated products. So there are certain products which are regulated. So if you see in a wide range, if it's used by a trained clinician, that really makes sense, and you won't find any complication. But if some places are using unregulated, normally now the young people, especially getting them online, that might develop a serious complication, which you beyond your limitation, beyond your fault. Anyway, so the increasing number of unlicensed cosmetic procedure are leading to complications. That's very common. If it's unregulated, as I said earlier, surgery botulism occur when botulism toxin spread beyond the intended injection site. And that's what happened in our case. This condition is rare, but can be life-threatening. So very early recognition is very important. If we do not recognize earlier, patient might be ended in life-threatening condition. Okay. So what happened? The patient has received the botulism toxin. So it's important of the case we have it. This case is also published online, so you can find in PubMed to read more about it. So patient has received botulism toxin, which she purchased. The patient has described that purchase online. The product was administered by a non-medical individual. It's per saying that that's a cosmetic clinic, but supposed to be done in the area which is specially made to get the Botox. However, she has been administered at home. The same vial has been used for the husband as well, the same places, forehead and the side of the faces. So they are quite young. I would say the young couple that they have got it. What happened then? Her husband was injected with the same vial, but he required a mechanical ventilation. But we are not going to focus on him, but we will more focus on the patient which I have picked up for this case. The case highlights a growing public health problem involving the cosmetic products. So we have got this is a picture has been get with consent from a patient itself, just to make sure that we can show you some. This same picture can be available in our the article. So consent has been taken from patient, and then we have to we have added this picture. You can see a bilateral-ptosis on the presentation, which is initially we have found not really bad. It got been worse while in the hospital. So this is a 35 female, which present with 5 days history of facial weakness, which she described difficult swallowing, the voice changes more particularly, and also the bilateral-ptosis, which suspect case of the cranial nerve deficit. However, the limb strength on April and nerve both were fine, so there was no concern. On examination, we have found she was fully alert, oriented. However, she was anxious. She was very confused of what's all around going on, why it's happening. Bulbar involvement was evident, which we can see that horsewise, slow tongue movement has been found on examination. Facial movement was impaired. Limb strength was normal for her. Peak expiratory flow, we have used it, which was 340, and the normal expected in 430. So such things on examination are found. So we put the differential diagnosis, could be myasthenia MS, can be GBS, can be another thing, but the last one, virgin botulism. Too early to say these things, but we have put it as a differential. Well, the investigation, we have sent the blood test, which come back normal. We have sent the ganglioside antibodies, which were also come negative. We rule out GBS, acid-like colon receptor antibodies. We can rule out the autoimmune, including MS. And also we have sent the serum to the UK Health Security Agency for the toxic analysis. So this is the blood results we have ordered, and you can see that it's normal. So we can see that things are, we rule out the other diagnosis. Right. We come out of management. We had to involve the medical team straight away. We also, however, this patient need a really close monitoring, and so we had to involve the intensive care unit, ITU, and we also administered botulinum antitoxin. Once we have confirmed that, we have also intravenous immunoglobulin therapy. Apart from that, the agent we have used is speech therapy, language. We have involved dietary modification. We also involved the physiotherapy and the neurology inputs in this patient. So this was a multidisciplinary team intervention in this case. Symptomatic other, we have involved artificial labia just to help it. These are all things we had to carry out. However, as I said earlier, we work in an ED department. We keep eye on the patient in case there's some typical cases. So the patient has been admitted in ITU for monitoring, but however, she doesn't require any mechanical ventilation compared with her husband, which was in severe case. So the botulinum toxin was sent to medicine healthcare product regulatory agencies. We also involved the laboratory analysis, which has confirmed the unlicensed product. The case was escalated to the UK Health Agency as well. The outcome, patient didn't require ventilator support. She gradually improved. We have found clinical improvement, swallowing function gradually improved. So she has been considered to be discharged. So, well, still she had maltosis, but we still think she's swallowing function was a lot better. Speech language therapy was a lot better, but still she requires some support. So we had arranged outpatient follow-up for her. Yeah. Okay, so this is the clinical timeline of the day one exposure. We just had mentioned that the patient has exposed to botulism, symptom onset in 5 days. Begin to appear 7 days, patient diagnosed. Illness in 2 days, and then treatment initiation 7 to 8 days, 7 to 8, and then 9 to 11. Closely monitoring IT, and then recovering to 12, and then have been discharged. So this is a timeline for this patient. The key learning point is about unregulated cosmetic injection. This is very, very high risk. Another thing is, if someone is working in ED department, sometimes we easily miss such type of cases when we don't. Sometimes we can put on sore throat, as her husband has been treated as a sore throat initially. And then he come back with the worsening symptoms and end up in ITU straight away. So this is very commonly, thanks, Emma. This is one of the exceptional case, but I mean, testing can commonly exist in the ED department in case if somebody, say, they have difficulty swallowing, and they also they don't have a clear history about they had a botulism, or they have it, but you're not really concerned. You might be put on the just normal reaction, and so this thing can happen. So we have to be vigilant to pick up such cases. Presentation may vary widely even when the same countervail is used. Early diagnosis endotoxin administration crucial for recovery. Healthcare professionals should be prepared for recognized cosmetic-related complication. So this is going to happen. I have seen it, certain references that you can find in the PubMed as well, and happen in different countries across the globe. So it's very high risk if hasn't been taken in properly. That's it. Thank you very much. Hope you have learned something very important from our presentation. And this case is really available on the PubMed as well to read more about it. Any question, please?
Thank you, Doctor, for your wonderful presentation. Any questions from the audience?
Secondary to flucloxacillin-induced liver injury. It's a case that had a successful response to rifampicin. It's actually a case of drug-induced liver injury, but the persistent hepatocellular secretory failure has its own entity. If you could kindly go to the next slide. To give you a bit of introduction about those who may or may have not heard about the persistent hepatocellular secretory failure. As the name suggests, it's very rare. It's rare but potentially life-threatening condition characterized by persistent dysfunction of hepatocytes in their capacity to secrete bile. So what will happen is that you'll have a persistent hepatocellular secretory failure, may be induced by drugs, toxins, or transient biliary obstruction. In certain cases, this dysfunction can persist for months following removal of the inciting factor, and if unresolved, may progress to fatal liver failure in the absence of liver transplantation. So the last bit is the important part. It's most drug-induced liver injuries. As soon as you stop the drug, you will hopefully see some improvement in the liver function. But in persistent hepatocellular secretory failure, that's not the case. One of the criteria to diagnose it is that the dysfunction doesn't resolve after removal of the inciting factor. So what will happen? An increase in serum bilirubin to more than twice the upper limit of normal, accompanied by elevated transaminases, signifies severe hepatotoxicity, and it actually carries a 10 to 15% risk of mortality if the offending agent is not discontinued. And this sentence is called Hayes' law. When drug-induced, what happens? When drug-induced, it represents a distinct phenotype of drug-induced liver injury, DILI in short, typically manifesting as profounding and sustained jaundice that may persist for months following withdrawal of the offending agent. As I said, unlike other form of DILIs, the entity is defined by the failure of bilirubin to normalize, so the jaundice persists even though you stop the medication. So for some of you, just wanted to say that drug-induced liver injury, it's two different mechanisms of DILI. There is intrinsic DILI, which is direct, where the dose of the medication does matter, and the DILI is this type happens when there is overdose. This is the case we see in paracetamol. It's an intrinsic direct DILI. When there is a paracetamol overdose, that's what happened. There is an idiosyncratic DILI, which we don't need to overdose, can have a regular dose of a medication, and that's what will happen. This is mostly persistent. That is the type of the DD that I am actually presenting. It can be hepatocellular, cholestatic, or mixed. It can be either you will see the raised bilirubin jaundice, or you might just see the raised transaminases. So if you kindly go to the next slide. So so the diagnostic criteria is for hepatocellular secretory failure includes serum total bilirubin, TBIL, that is total bilirubin of more than 255 micromole per liter, persistent elevation of total bilirubin for more than 1 week following withdrawal of the offending factor, exclusion of obstructive cholestasis on imaging, an absence of pre-existing chronic liver disease. So the patient shouldn't have any of these and should have total bilirubin of more than 255 micromole more than a week of or stopping the medication. If you kindly go to the next slide. So epidemiology, as you can see, the causative agents of cases of DD are like numerous, with antibiotics are being the most common cause, and analgesics and antineoplastic agents comprising the least contributing agents. More than 900 agents are known to cause liver injury, and that is the sole or the one of the most common causes of withdrawal of a medication from clinical use. The overall incidence of drug-induced hepatotoxicity in general population has recently been estimated at approximately 14 cases per 100,000, and in Western countries actually. So as I said, the antibiotics being the most common, with 45.4% of drug-induced liver injury, followed by herbal and dietary supplements at 16%. We can go to the next slide. The treatment of most drug-induced liver injuries, you withdraw the offending agents, and you will see the improvement in liver function. However, in the persistent hepatocellular failure, secretory failure, the clinical course is variable, with some patients experiencing spontaneous resolution, while others progress to end-stage liver failure requiring transplantation. Until today, the only medication that actually can work is rifampicin, remains the only reported medical treatment capable of significantly improving bilirubin clearance. So how it works is the primary effect of rifampicin is inducing CYP3A4 expression, through which it activates pregnan X receptor. What will happen when that pregnan X receptor is activated? This increases 6-alpha hydroxylation of bile salts, compound which can subsequently excrete in urine. In addition of that, what the rifampicin can do is also can do conjugation and excretion of bilirubin enhanced through induction of UGT1A1 and ABCC2. A lot of genetics involved here and pathophysiology. I'm not going to bore you with that, but that is how it works. But in essentially, it's either excreted through the urine, or it detoxified bile acid metabolites through biliary or urinary excretion. Let me go to the next slide. So now I'm going to start the case presentation. This is this is what prompted me to read and do this case presentation. It's an 80-year-old Caucasian gentleman that I saw in the hospital when I was doing my gastroenterology internal medicine rotation. Presented to GP. He went to GP on 29th of September 2025 after noticing a scleral icterus, dark urine and pale stools, along with unintentional weight loss of 3 to 4 kg over preceding year. So the GP, what the GP did, initial bloods sent showed that raised bilirubin, some of the other transaminases were raised. So from those who work in UK, they might know that in the UK, anyone who presents with painless jaundice to GP, now there is a pathway which is called pancreatic rapid diagnostic pathway, and the GP can organize a CT pancreas, which happens quite urgently, and depending on the findings, then they are referred to the next step. In his case, he had his pancreatic CT on 4th of May, which revealed no pancreatic abnormalities but suggested a probable collapsed gallbladder containing gallstones. So this gentleman is past medical history wise. He was known to have atrial fibrillation, coronary artery disease, and stage 3 chronic kidney disease, hypertension, and hip osteoarthritis. You kindly go to the next slide. So this is the CT. There are two slides which shows the CT findings of figure 1 and figure 2, which is the CT pancreas initially organized by the GP, showed normal body, tail, and the head of pancreas, indicated by A, B, C, and the next one, if you can see. Next slide, please. Okay. So what happened was that whilst he had the CT, I think when he was waiting for his CT report, he presented to same-day emergency care on the 7th of May with worsening jaundice and associated pruritus. A decision was made to admit him for further evaluation and management. So he was admitted to gastroenterology ward. This is when I saw him first. The patient denied any abdominal pain except for mild suprapubic discomfort. Also denied fever, chills, rigors, any of the symptoms that might be related to cholangitis. Diarrhea, recent travel, excess alcohol intake, recreational drug use, or use of any herbal medication. His regular medication actually included rosuvastatin, ramipril, omeprazole, and warfarin, out of which warfarin and rosuvastatin was stopped due to the deranged liver function. After further questioning, he reported he had received 2 courses of flucloxacillin, 500 milligram 4 times a day, which is very appropriate dose, not a high dose, and it's a routinely prescribed by the general practitioner for a soft tissue infection approximately 1 month prior to he initially noticing jaundice. On examination, as I mentioned, visibly jaundice didn't reveal any abdominal tenderness apart from a bit of suprapubic discomfort. No hepatosplenomegaly, ascites, or stigmata of chronic liver disease. We kindly go to the next slide. So this is his investigation. If we go to the this is his investigation. If you see initial bloods, that is on 29th of April, done by the GP. There was no INR on that one, but it showed urea at 6. I've given reference ranges for those who might not be familiar to millimole, micromole. So urea of 6, creatinine of 107. That was normal for he slightly raised, but he's just bear in mind he had chronic kidney disease stage 3. With bilirubin initially of being 144, ALP current phosphatase of 362, and ALT of 235, and significantly raised gamma GT. And on admission, this is the day he presented to the same day emergency care. INR was done. INR was significantly raised, and he denied taking his warfarin out of ordinary dose. He's taken always the same dose. And INR was 9. The urea was icteric. It was the lab couldn't run that. Creatinine was still 108. Not bilirubin jumped to 287, and with the ALP and ALT not significantly different. So we do have the day 5, day 10. I didn't put much data with he had daily bloods, and until the day 25, as you can see, his urea was ecteric. His creatinine became 225, so he had a bit of slight deranged renal function. His bilirubin was significantly raised at 575, with ALP being ecteric. And if you see on the day 13, his bilirubin was actually highest at 760. If you go to the next slide, please. So further investigation was done. This is for any of the patients that we come with deranged LFTs, that we do a non-invasive liver screen, including iron studies, immunoglobulins, alpha-1 antitrypsin, ceruloplasmin, amylase, hepatitis A, B, C, E, CMV, EBV, leptospira, autoimmune markers, including anti-nuclear antibody, anti-smooth muscle, anti-mitochondrial, liver, kidney, and anti-LKM1 antibodies, soluble liver antigens, and ANCA. All of them were absolutely unremarkable. There was nothing wrong with those. So it was decided to do further imaging, including abdominal ultrasound, which was done on 10th of May, and it just showed the gallbladder, and but nothing else. Just some small gallstone, but no biliary dilatation. MRI and MRCP was done on 14th of May. Did not identify a definitive cause for the patient jaundice. If you kindly go to the next slide, you can see the images. That is the MRCP, which let me go to the next slide. So this is a MRCP showing no biliary dilatation, no calculi within the common bile duct or cystic duct. Can't see the pancreatic duct. As per radiologists, if you can't see the pancreatic duct, it's normal. If you can go to this next slide. So what was done was, so given in the absence of identifiable cause of the patient's persistent jaundice and continuing rise in bilirubin, it reached 760 micromole per liter on the day 13th, with ecteric ALP and ALT of 140 on the 20th of May. Despite supportive measures, decision was made to refer him to specialist hepatology and liver transplant center for further evaluation. So the hepatology team suspected that he might have what we are doing the presentation on, hepatocellular secretory failure secondary to flucloxacillin-induced drug-induced liver injury, and recommended a liver biopsy for diagnostic clarification. So he had the liver biopsy on 19th of May, which showed the initial histopathology from that's A to D. So features of acute hepatitis and biliary stasis. So if you have a look on the histology A and B, it was reported that portal tracts show moderate increase in inflammatory cells, which are rich in neutrophils. And the slide C showed containing lymphocytes and plasma cells. So the consensus was that the presence of neutrophil-rich inflammatory cells infiltrate and prominent cholestasis was suggestive of drug-induced hepatitis. And the slide D showed the cholestatic hepatitis with duct injury and duct loss consistent with flucloxacillin-induced liver injury. So this was confirmed on the histopathology. They go to the next slide. Yes. So then this is on the 4th of the 4th of May. On the 4th of June, 2025. After the initial histopathology was done, it was sent to the the transplant, liver and transplant center, and they confirmed it. So then on the 4th of June, it was decided that the patient should be started on rifampicin 150 milligram twice daily and a prophylactic fluconazole to address presumed persistent hepatocellular secretory failure secondary to flucloxacillin-induced daily. So the patient overall liver and renal function started to improve after we started this gentleman on rifampicin. So from the kidney point of view, some of you might have a question that he had an acute kidney injury on top of his CKD. It was discussed with renal team in a different center, and they presumed that this was not secondary to anything else apart from bile cast nephropathy, and advised to give a gentle hydration and keeping a neutral fluid balance. Their opinion was that once hepatic function improve, more probably renal function will improve alongside as well. So if you can kindly go to the next slide. Yes, it's the slide. If you see on the 4th of June, that is the day the rifampicin was started. His INR at that time was 1.2. From INR point of view, it wasn't reversed or anything. It was just the warfarin was withheld and INR resolved. His urea was ecteric, creatinine of 248, bilirubin of 588, ALP still ecteric, ALT 93, and the gamma GT was unfortunately not done. It's not routinely done, the gamma GT in the UK, part of the liver function test. So you can see the day 1 and day 2, and I think around day 5, when the bilirubin started to slowly come down, and the bilirubin was 383. That is when it was decided that it was in the patient's best interest that he could be discharged and followed up as an outpatient with regular blood tests. And the further blood tests, if you see the day 20, day 27, 48, all of these blood tests were done as an outpatient, and his bilirubin significantly improved. His symptoms started to improve around day 5 anyway, when his bilirubin started to slowly return to normal. Not normal, but it was going down. And on the 27th of August, his bilirubin was recorded at 30. And if you see the creatinine improved to 139 as well. It was still not back to baseline, but it was improving. And that is all with just the treatment of rifampicin given for the persistent hepatocellular secretory failure. If you go to the next slide. So yeah, so that is you can see, this is just a graph, the trajectory of the serum bilirubin. The arrow shows where we started the rifampicin. Where before the hospital admission and after the hospital admission, you can see the bilirubin was kept going up. Now, there was days that it was slightly down, but it wasn't returning to the normal at all. And so when the rifampicin was started on the 4th of June, you can see the bilirubin trend, it's down going. If you can go to the next slide. Okay. From a discussion. Discussion is in patient presenting with drug-induced hepatocellular jaundice, the risk of progression to death of liver transplantation has been reported at 11.7%. Among the therapeutic groups of medication known to cause idiosyncratic liver injury, antibiotics run fast in terms of causative agents. Among the antibiotics, amoxicillin clavulanate, coamoxiclav, represent the most frequently associated cause of DILI. Real-world evidence regarding the use of rifampicin in cholestasis, particularly in patients with marked jaundice, remains limited. In a study conducted between 2016 and 2020, 14 of 16 patients demonstrated improvement in liver function tests defined as reduction exceeding 20% at 4 weeks following initiation of rifampicin therapy. And these findings support the consideration of rifampicin in the management of the current case, as you can see, where cholestasis has been demonstrated through histopathological findings from the liver biopsy, and a significant reduction in bilirubin was also evident in the data presented. If you kindly go to the next slide. So conclusion is that the case illustrates a rare presentation of flucloxacillin-induced hepatocellular secretory failure, complicated bile cast nephropathy in an elderly patient manifesting as severe persistent cholestatic jaundice with delayed recovery despite discontinuation of the offending agent. The comprehensive evaluation, anyone present with this type of jaundice is going to have a comprehensive evaluation, including imaging and extensive laboratory testing, may be unrevealing in this case, and despite initial diagnosis uncertainty, timely specialist referral and liver biopsy remains a valuable tool for confirming hepatocellular cholestasis and gynae management. We go to the next slide. Apologies. Targeted therapy with rifampicin can lead to significant symptomatic and biochemical improvement of both hepatic and renal function, the renal function being in this case particularly. Clinicians should maintain a high index of suspicion for drug-induced liver injury in patients presenting with unexplained jaundice, particularly in those with recent antibiotic exposure, early recognition, timely specialist referral, and a multidisciplinary management are critical for optimizing the outcomes. And that's about it. The last slide would be the references. If anyone have any questions.
Thank you, Doctor, for your wonderful presentation.
Yes, thank you. Thank you for your time.